Welcome to the Commission's panel discussion on how to support people living with mental illness and problematic alcohol and drug use. I'm Penny Armytage, the Chair of the Royal Commission into Victoria's mental health system. I'm joined by my fellow commissioners, Professor Allan Fels, Dr. Alex Cockram and Professor Bernadette McSherry. On behalf of the Commission, I acknowledge the traditional owners of the land on which we meet, and I pay my respects to their elders past, present and emerging. Before I commence, I would like to thank Dr. John Reilly, Professor Dan Lubman and Dr. Stefan Gruenert for taking the time to participate in today's panel. I know that each of you have already contributed significantly to the Commission's work in the development of your witness statements and in the preparation for today's panel discussion. We are conscious that this contribution has occurred during the challenging time of the current pandemic, and we appreciate that you will have had other pressing work related to the pandemic response. The pandemic and its mental health impacts has emphasised to the Commission how critical a stronger mental health system for Victoria is now and into the future. The purpose of these panel hearings is to explore and contest ideas through a shared discussion. While the forum for our hearings has evolved in the current environment, we know that the most powerful insights for our work occur when we engage in discussions with experts and with those with lived experience. The Commission has continued to engage widely across the community, utilising online forums such as this to continue its engagement work. This panel is focused on how to support Victorians who have mental illness and co-occurring drug and alcohol issues. It will focus on how the future mental health system can better support adults and young people, how the mental health and alcohol and drug sectors are currently responding to people with co-occurring needs, and what lessons can be learned from each other's jurisdictions. In our community and expert consultations, we frequently heard about the complex and unique challenges for consumers with co-occurring mental health and substance use issues. The panel has been convened because the opportunities to reform extend beyond the mental health system and into other service systems. We know that currently many people with co-occurring mental health and substance use issues are not receiving integrated care. Some consumers are falling through the gaps between mental health and AOD services, or are experiencing lengthy delays to access either. The Commission has received submissions that highlight how consumers have bounced between mental health and AOD services, deemed too unwell for AOD treatment, or ineligible for mental health services because of their substance use. These experiences can seriously undermine the health of consumers as they wait for access or attempt to navigate complex and siloed services. For those that do seek help, we have been told about experiences of double discrimination and stigma associated with mental illness and substance use. For example, a participant in our community consumer focus group explained that you be honest and say you use drugs. They give you lectures about how bad drugs are for your mental health, but for me, it's the only thing that makes me feel better. We also heard about the impact of these issues on consumers and families during our community consultations. For example, one family told us there is no integration for people with mental health issues and AOD issues. There's no facilities, there's no referral points, and the constant refrain I got from her mental health team was that until she recognised she had a problem with alcohol, there is nothing we can do. This situation is concerning, considering the insights from experts across many sectors that the co-occurrence of mental illness and substance use should be understood as the expectation rather than the exception. The Commission understands that estimates of the prevalence of co-occurring substance use with mental illness nationally range from 25 to 68% of people with mental illness. The Commission has also heard of the work of many dedicated and compassionate professionals across the mental health and AOD sectors, including those who are working to bridge these gaps. During our community consultations, we heard about how even a short intervention at a critical point for a consumer can place them on the path to recovery. When my son was going to discharge himself following an alcohol-induced admission to hospital, they had one psychiatric nurse go and see him. They spoke with him for 20 minutes and he agreed to become a voluntary patient and in an inpatient unit. This changed his life, according to one participant. Recently, we have met with primary care and community health services that are providing integrated care for consumers with co-occurring mental health and substance use issues. We have heard from consumers and carers who access these services about how a welcoming, non-judgmental and holistic response from empathetic and skilled professionals has changed their lives. We have read with keen interest your respective witness statements, and it is evident that you bring a wealth of expertise and experience to this topic, along with thoughtful and progressive reform ideas. There are areas of broad agreement across your statements, including the need to improve consumer experience and address service silos, and an acknowledgement that both services have much to learn from each other, and that there is opportunities to increase the capability of both workforces. The benefits of integrated responses for consumers, and the need to engage young people through youth-appropriate and holistic services. The statements were in agreement on the importance of integrated care, treatment and support, particularly for people with more complex support needs. There was also agreement on the important role that peer support can play and the history of peer support, particularly in the alcohol and other drugs sector. There are also key differences, including different perspectives on how integration should be pursued and at what level. Your witness statements also contained a breadth of research and local and international examples of how to address these complex issues, for which we thank you all. The purpose of this panel is to address both the areas of agreement and to understand more deeply divergent views. We are also keen to learn more about what reforms you would each see as vital for the future mental health system here in Victoria. Today's discussions will be facilitated by Counsel Assisting, Fiona Batten, and I and my fellow commissioners have largely a listening role. Before handing over to Fiona to outline the logistics and parameters of today's panel's discussion, I would like to once again thank you for the time in assisting the Commission with our deliberations. We look forward to hearing your insights and perspectives on these complex and challenging issues. Thank you, Fiona.
Thank you, Chair. I would first like to introduce our three panel members, and then I will outline the main areas to be discussed. The introduction is necessarily very brief and it doesn't do justice to their experience and contribution, to which I'd refer everyone to their witness statements. In no particular order, Professor Dan Lubman trained as a psychiatrist and addiction medicine specialist. As the Executive Clinical Director of Turning Point and Professor of Addiction Studies and Services at Monash Health, Professor Lubman provides strategic, clinical and academic leadership. Professor Lubman is also the inaugural director at Monash Addiction Research Centre at Monash University. Professor Lubman has published a substantial body of work, and his contribution to the field has been recognised through a number of awards. Dr. John Reilly is the Chief Psychiatrist and the Chief Mental Health, Alcohol and Other Drugs Officer in Queensland. The latter title reflects the integration of mental health and alcohol and other drug services in Queensland. Dr. Reilly has worked in clinical or medical director roles for mental health services or components in both Victoria and Queensland for over 20 years. He has clinical expertise in addiction and has a particular interest in quality improvement, service development and governance. Finally, Dr. Stefan Gruenert is a registered psychologist and the Chief Executive Officer of Odyssey House. Dr. Gruenert has worked in the alcohol and other drug sector for 20 years as a clinician and manager, supporting people with alcohol and other drug problems and their associated mental health issues. Dr. Gruenert is responsible for managing the range of residential and community-based services Odyssey House delivers. He is a former president of the Victorian Alcohol and Drug Association and a current director of the Victorian Council of Social Services. As the Chair mentioned, each panel member has provided the Royal Commission with a written statement which will be published on the Commission's website. Thank you to each of you for your energy and dedication you've put in both into your statements and to this panel process. In this panel hearing, to assist the Commission consider how people with mental illness and substance use issues can be best supported, the panel discussion will focus on 5 areas. First, the strengths of the approaches of the alcohol and other drugs sector. Second, addressing the needs of people with mental illness and substance use issues. Third, integration at a governance and policy level. Fourth, increasing workforce capability. And finally, the priorities for the allocation of resources. I will start by asking questions until approximately 11:30 and then give everyone a break for 10 minutes. And we'll continue asking questions, and then I'll hand over to the chair at approximately 12:20, 12:30 for the commissioners to ask the witnesses questions directly. So our first topic is the treatment philosophy and approach. The Commission understands that a strength of the alcohol and other drugs sector is that it adopts a holistic approach to treating consumers. In your experience, what are the strengths of the treatment approaches of the alcohol and other drugs sector? Dr. Gruenert, can I ask you to respond to this first?
Thank you, Fiona and Commissioners. I think 2 points I should make around the context of response to this question. And the first one is that whilst there is some overlap of clients across mental health and alcohol and other drug sector currently, they work with very different cohorts by and large, which means that the strengths and weaknesses of one sector can't necessarily be compared with the strengths and weaknesses of the other. And I think in most cases, the alcohol and other drug sector is working with moderate to severe alcohol and other drug problems and mild to moderate mental health issues. And those issues are things like anxiety, mood disorders, PTSD, personality disorders, and the effects of trauma. And mental health services, in contrast, are dealing mostly with moderate to severe and low prevalence mental health issues, and often very mild to moderate drug and alcohol issues. So in terms of the actual strengths, I think some comments made by the chair about consumer input are really important. I think the safety and the welcoming environment that's non-judgmental and that gives consumer choice are clear sort of markers of a strong drug and alcohol sector. I think the integration of peer support is a key strength of the alcohol and other drug sector, and that it's generally experienced by consumers as an egalitarian partnership where they feel really part of the decisions and part of the involvement in that work. And I think that occurs both at the community-based service level all the way through to residential programs, and it's also part of the system for mild, moderate and severe issues around drug and alcohol. And I think it really brings much more effective outcomes, as we've seen in research, for participants in sustainable recovery when there's strong peer involvement. And finally, at this point, I'll probably just add also another strength is the capacity for the drug and alcohol sector to integrate the care and support from a range of different disciplines, again, in quite a partnership and egalitarian way. And that includes, medicine, psychiatry, psychology, social work, nursing, and the lived experience, without a strong divide between clinical and psychosocial services that often exist and are referred to quite frequently within the mental health system. And I think that assures that all of the associated health, behavioural and social issues are addressed within drug and alcohol services, including forensic and issues of criminality, legal issues, vocational and housing needs.
Thank you, Dr. Gruenert. Professor Lubman, can I turn to you next in terms of the strengths of the AOD sector?
Yeah, thank you, Fiona, and thank you to the commissioners for this opportunity. So I fully endorse the comments made by Stefan. I suppose there's a couple of things I'd just like to raise in thinking about this point. Nearly everyone that we see in the alcohol and drug space are using drugs to solve a problem, to help with dysphoria or distress or issues in their life. So they're presenting to us with a solution to the problem they have that's not working for them. And so the alcohol and drugs are emotional analgesics that help them deal with underlying mental health, distress, life, a whole range of life complexity. And so when we're seeing people in the alcohol and drug space, our core focus is understanding that the drug use is the solution to their problem, and we need to work out what the actual problem is. And so we need to think holistically with them to help them try and understand what is underlying that, because for many people that we see, they're not really aware why they use drugs. They've just used drugs for such a long time to address an underlying issue that over time the addiction itself has been the primary issue, and the actual reason they started using underlying that, which might be related to trauma, untreated mental health, a whole range of other life circumstances, might be lost. So a big goal for us is around how we engage and work with people to try and understand where they're coming from and trying to address the answers, not only just for how we treat their alcohol and drug issues, but how we treat the issues that actually led them down that path in the first place. I think it's fair to say that the recovery models in both the mental health and alcohol and drug system are pretty similar theoretically and, you know, in terms of policy documents. But I think it's really important to consider that the way in which the systems are designed actually influence how those principles are actually rolled out in practice. And I think it's fair to say that the focus within the mental health system on risk, on a mental health act, so an involuntary system, it has a major colouring in terms of how the system sees and interacts and works with people, because there's a whole issue around the level of risk that needs to be managed and concerns around when people are not able to make informed decisions and the system has to step in. And I think that colours a lot of the decision making and a lot of the way in which people are approached and dealt with in the system. In contrast, in the alcohol and drug system, we manage people who are incredibly risky, but we don't have that involuntary frame. We don't have that risk frame. So for us in the alcohol and drug system, the only thing that we have, you know, to be able to work with people is you know, a willingness to engage, a willingness to be non-judgmental, to be empathic, to hear where they're coming from. So our tools and our approaches and our models of care have to be about how we actually walk alongside people, how we encourage them to be part of the system, how we hear what their issues are, and how we, you know, develop interventions that actually work for them. Having worked in the mental health system where the focus is much more on risk and just the nature of the demand on the mental health system, often when you're working that system, you don't have the luxury of waiting to work out and understand people's problems and you know, be able to have the time to actually understand where people are coming from. It's much more that risk-based system. And because of that, because the system, and I think as we said throughout the, our submissions, because there's been a whole issue in a generation of health providers not being able to be upskilled in the area of addiction, the mental health system doesn't understand that drug and alcohol use is a solution to a problem. So generally what happens is when you come in the mental health system, the mental health system says, well, drugs and alcohol make your mental health symptoms worse, so you should stop using them. And so, you know, often the involvement that I have in the mental health system is often working with mental health providers to help them understand why it is people choose to use alcohol and drugs. And it's not because they're being difficult and because they're sabotaging their treatment. It's because that is, as Penny's highlighted, you know, the key solution to how they deal with trauma and distress in their life. And so, you know, the focus of our treatment is, well, how do we find an alternative solution that actually is just as effective? Because I cannot tell somebody to stop using drugs if I'm not giving them something that is effective for them to use. They're not going to stop that if they've been doing that for years without an alternative that is just as effective. So for me, I just wanted to raise those issues really, which is around issues of differences in the philosophy and approaches of the systems based on the fact of risk and the Mental Health Act, which I think colours the mental health system, the need for us to engage. And so our models of care are very much about that, and the peer experience is critical in that, making people feel that there's visible champions. And the other issue I just wanted to raise is just the stigma issue. The stigma issue is enormous. As, you know, addiction is, I suppose, you know, it's been repeatedly identified as one of the most stigmatized health conditions, you know, in the world. And so the media, you know, what we hear within health professionals and even the mental health system is that, you know, you shouldn't use drugs, they're bad. And so because of that, for many of the people we see, they don't want to go to services. They don't want help because every, you know, whether it's in the media, in the family and friends or service systems are constantly telling them that they're making wrong choices. If it was just a matter of choice, you know, people would be able to just stop using. But the issue is this is a solution for a whole range of other problems, and this is an actual mental health condition, as I sort of reiterated my statement. And so we need to also acknowledge that stigma is so prevailing that the alcohol and drug systems philosophy, recognizing how stigmatizing these conditions are. So it's really critical that we have settings and services that are welcoming to people and see them where they're at and don't judge them. So we have to create an environment that recognizes that profound stigma. And unfortunately, the mental health system is, still has a very, because of issues of lack of understanding around the issue of addiction, because of years of, a failure to train that, that professional group. Stigma is still very strong around the alcohol and drug issue, and that becomes a very unwelcome environment for people presenting to those services. So I've probably said enough.
Thank you, Professor Lubman. I'll give you more opportunities, don't worry. Dr. Reilly, can I turn to you for the strengths of the alcohol and drug sector?
Yes, thank you, Fiona, and thank you, Commissioners. I think that I'm just trying to think what to emphasise in following the other discussions. I think what I've tried to highlight is that I do think that sometimes there's this notion of the AOD sector and the mental health sector, and this question does include that. And I think we just have to recognise some of the underlying perhaps thinking around that, because that still seems to imply some of the things that Dan and Stefan touched on, which are, I think that it can be an unfair comparison because we're talking about the AOD sector as being separate, not having as it's been highlighted in philosophy, perhaps of more coercive treatments under mental health acts and not being risk focused. But I do think that if you look, I don't think there is any great difference. I think that in the AOD sector as opposed to a broad mental health sector, I think that the comparison that we're talking about sometimes is between a broader AOD sector with regard to multiple different types of services with a narrowly clinical mental health sector, which is focused on the treatment of the most severely mentally ill. And so in a sense, I don't think that it's a fair or reasonable comparison. So I think with that proviso, I don't disagree with some of the other things that with what Dan and Stefan were saying, but I think it's important to put that context in because I think that good mental health treatment follows all of the same principles that we've just been discussing with regard to consumer choice and involvement and engagement and motivation to change. But clearly, if we're looking at a severe end of the mental health disorder spectrum with consumers and patients that perhaps have lost capacity and are posing risk, then there is an expectation on mental health services that they manage that risk. Whereas, as Dan said, people with severe alcohol and other drug problems may also pose risk, but often, in a sense, the AOD sector doesn't take on the management of that risk. That risk is left with the patient and then really with wider community risk management processes, whether that's police or other things, as well as potentially mental health services at times of crisis for people with severe or with significant substance use disorders. So otherwise, I would agree with the strengths. I think that those are the provisos that I would add in.
Okay, thank you. I'm going to keep, I know you've got a lot to say, but I'll keep moving you along with the questions so we get through the main content. The second topic is addressing the needs of people with mental illness and substance use issues. And the first question seeks to explore what integrated care should look like in three contexts. So I'll outline the question in full, and then Dr. Reilly, I'll ask you to respond first. To best meet the needs of people with mental illness and substance use issues, what should integrated care look like for people, first, who present to a crisis setting, second, who may benefit from assistance in a bed-based setting, and third, who may benefit from treatment in a community or a primary care setting?
Sure. So look, I think that what we're focused on here is people with mental illness and substance use issues. So I guess what I would highlight there is, well, really though, we're talking about people at a particular level of severity, most likely, of mental illness and of substance use disorder. And if that's what we're talking about co-occurring substance use and their other mental health disorder, which is causing them to seek treatment in some way, in this first instance to a crisis service, but obviously to health services more generally with any of these. So I guess then along the lines of the 4-quadrant model that I attached, I'm really thinking about that severe substance use disorder and severe mental illness group. And as I've outlined, what we're really talking about in that case, at least in crisis, is people who are probably presenting to a mental health service specifically. They're probably presenting, for instance, to an emergency department or some form of an acute crisis setting. And so I think, and they're really presenting, although they've got a severe substance use disorder, they're presenting with some kind of crisis that could be called a mental health crisis, you know, suicidality or homelessness that's causing them distress, something of that sort. In that situation, if they also then have a severe substance use disorder, really the issue is trying to assist that person to recognise, a little along the lines that Dan was just saying, what's the actual problem right now and how might we then be assisting that person to manage that. And that might be around suicidality. It might also then be around alcohol use or other substance use. And then other psychosocial stressors at present and what's going to be a solution for that person. And really then that comes back to looking at integrated care, ensuring that the person, the clinician or other staff working within that crisis service actually has a good understanding of how to engage that consumer or patient or client in a, in a process of assessment, working out with them collaboratively what's going to be most appropriate strategy to assist them at this point, and really having the knowledge and the skills to be able to work with that person, to do that effectively, and to be able to go across a range of different clinical needs, and for that to be, in that sense, a one-stop shop where they're able to manage those, at least the health-related issues effectively, and they've got good links then with other social situations. And in that, and really, therefore, in my mind again, that seems to come back to having those mental health clinicians feeling capable, confident of managing mental health issues broadly, and that should include substance use, and that they're also then able to connect up with appropriate psychosocial supports, as I said. Now that therefore comes back to staff, it comes back to training, it comes back to attitudes. So we can touch on those later. I think with regard to a bed-based setting, I'd simply be saying the same thing. We've already touched on high prevalence. Commissioner Armytage started with that we have to recognise that they are the norm and that therefore all of our clinical services, all of our staff need to recognise the importance of managing co-occurring substance use disorders. And I think that with regard then, so I would simply say, well, that actually requires us just to acknowledge that's just the norm, and we need to have service systems which treat it as the norm, which again brings me back to the same issue, right? And so that they're not compartmentalised. So that's about simply having that the mental health service system has to see this as its core business and then develop knowledge, skills and structures which support that. And I think that the final one's much the same. If you talking about community specialist services, it's the same for community mental health services currently, that's what they should be doing. For the consumers that are presenting and receiving treatment within those community mental health services. If you're thinking then, it says primary care setting, then really that's about having whatever the specialist service is that's been involved, in that case in transition to primary care, ensuring that all appropriate health-related disorders that service should be looking at have been addressed, that the needs have been identified and treatment recommendations have been made that supports the general practitioner or other primary care provider in continuing that care if it's now appropriate for it to be devolved to that level. So, thanks.
Thank you. Professor Lubman, can I turn to you next? Do you need me to repeat the question?
No, that's okay. So I think a couple of comments to start with. I mean, I think substance use is one of the main precipitating and predisposing factors to mental illness. It's also consistently shown to be one of the strongest predictors of poor outcomes in terms of relapse and readmission. So it's central to the treatment of mental illness. If you don't treat the substance use, essentially you can't treat the mental illness. So for me, treatment of the substance use is indistinguishable across those three settings. If you don't treat it, you're not doing anything for the person's mental health. And so it has to be a core part of that treatment. And I suppose the nuance is the level of intervention at those particular settings. So for me, if somebody presents with a heart attack and they have underlying diabetes, to say that we would not, in any way recognize that diabetes or think about stabilizing that diabetes in terms of treating the heart attack, would be negligence in terms of a medical situation. So for me, it doesn't mean you have to have a specialist in diabetes in the cardiology ward helping people deal with a heart attack, but it needs to be recognized as something that needs to be stabilized in the short term, and that there needs to be specialist review in terms of its treatment if it's a major factor in terms of a cause for that heart attack. So for me, it's a core component. Work that we've done and other people have done have shown that it's the biggest predictor of relapse following inpatient admission. So if it's the biggest predictor of relapse in terms of inpatient readmission within the next 2 to 4 weeks, it beggars belief that it isn't a priority in terms of a management plan, in terms of ensuring that person stays well and remains well out in the community. So for me, I think everyone would agree that having a capable workforce that has minimum knowledge and understanding of how to manage these issues. So we would expect doctors managing heart attacks to sort of understand diabetes and be able to manage, diabetes at a basic level. Same here, we would expect that our workforce in the mental health space would have a basic understanding and capabilities in managing substance use. And then in the particular, depending on the setting and the models we want to put in place, which we'll come to later, it's about how do we bring in that specialist expertise to provide additional support depending on where people are at. So in terms of an acute response, obviously we need to prioritize the main presenting complaint, but we need to be acknowledging and working with the underlying substance use. As the person comes into the recovery phase, we need to ramp up that support around substance use to make sure that their recovery pathway is optimized and that we minimize any risk of relapse and we ensure their well-being. So probably that's enough for me.
Okay, thank you. Dr. Gruenert?
Endorsing what Dan has said and much of what John has said, just a couple of additional points I'd like to raise. I think it's important for us to remember that much of the drug and alcohol use in Australia is neither problematic or does not necessarily relate to a diagnosis of substance use disorder. And the mere presence of someone's use of drug or alcohol needs to be considered, but not necessarily treated or managed whenever they're presenting in any setting. And so I think the response that we take really needs to consider, the level of severity or what we're actually talking about. And so for me, the kind of critical things, regardless of the setting, are the capacity of the environment, the workforce, the staff to be able to identify what's going on, to be able to assess and understand the level of severity or the impact that's having, and then to be able to have the skills to manage and respond in an appropriate way. So from my perspective, I don't believe integrated care equates to integrated service systems. And I think integrated care can be done in a single setting within both sectors. And that's the ideal way to provide integrated care. And I think it's an appropriately resourced drug and alcohol system and a mental health system can respond to both a person's presenting mental health or drug and alcohol issues for all but probably the most complex cases with the right trained staff and support. If we're looking at the different settings, I think it's fair to say that in any crisis, and whether that's been presented in ED or to mental health service or to drug and alcohol, that helping people to feel safe and welcome so that you're at least getting a de-escalation of behaviours and a sense that people are empathic and they care and they're seeking to understand you is really critical. And so the knowledge and skills of the staff to be able to do that in a credible way are critical. And again, we need those skills across both mental health and drug and alcohol to be able to do that, so that the language used, the way people are approached when they're in crisis is suitable. And I think I've referred to in my submission that much of the crisis, is presented in a hospital setting where you either get a very sort of clinical medical response or a security response around the crisis. And we really need other responses that are much more behavioural, that are understanding mental health and drug and alcohol when people are presenting in that crisis. In terms of the bed-based settings, I think it depends what bed-based setting you're talking about. If we're talking about inpatient acute mental health, then again, the points Dan made are really critical about identifying, someone's drug use been problematic, dependent. Is it one-off episodic? Is it just an intoxication that brought them there? And what's really going on underneath, the assessment around that, so that the better understanding of the impacts on their mental health can be understood. If you're talking about a residential setting in drug treatment, the key focus of that setting is really seeking to develop the skills and the capacity to address all those underlying problems that Dan talked about right at the start, that are really the reason why people are using drugs, and give them viable alternatives to that. And so the key need in that setting is to be able to have the right people around as part of the team to be able to manage and contain people's mental health symptoms until they can get to a point where they've developed the strategies and things to manage those on their own. And that may be pharmacotherapy, but it also might be a whole lot of psychosocial strategies. Again, in a community setting, having staff and people who are skilled up and knowledgeable about both mental health and drug and alcohol is critical. So again, you can do that, identify, assess, and then manage or integrate strategies into their care or treatment plan, if that's even needed, because it's not a way, their drug use may not have been an issue, or the alcohol use may not have been an issue in that setting. And you don't want the mere presence to suddenly trigger, oh, we can't work with you, you've got drug and alcohol issues, you need to go over there. So for me, regardless of the setting, there's those fundamental things that need to be in place to make sure that the response actually matches what's going on for someone and at the right level.
And just before we move on to the next question, you've all talked about a base level of knowledge of the workforce, but the potential need for more specialist expertise in particular circumstances. What about the scenario where someone has the most severe complex mental illness and the most severe substance use issues, which I presume would be a substance use disorder? What does the integrated model of care look like in that circumstance? Professor Lubman, perhaps I'll turn to you first.
So I think when we're talking about severe in both ends, so we're talking about a severe substance use disorder and a severe mental illness. And I think what's clear in all our submissions, and particularly the work that we've done previously, is that there needs to be a specific model of care for that patient group. There isn't a model of care at the moment that exists. At the moment, we're asking our addiction services and our mental health services to sort of make do with the models they currently have. And I think what's been clear through what we're hearing from consumers is the current response is inadequate and doesn't meet the needs of people presenting with those issues. So there needs to be the development of a new model of care that recognises that the complexity of severe mental illness and severe substance use disorders and actually meets those needs. And there's some, I think in the submission we put in and other people have put in, there's really great evidence-based models of what works in terms of models of care for that patient group. They just don't currently exist in Victoria, and we don't have a system that is able to escalate. I think that's one of the biggest issues that when we talk throughout the integration piece is the need to understand the ability for the system to escalate and to be able to identify, what an issue is and whether that current response of the system is able to meet the person's needs. And if it's not meeting those needs, there's the ability for the system to escalate to another model of care that isn't just giving more of the same stuff by more of the same staff. It's a very nuanced and different model of care that has been shown to be effective and that has been shown to be and resourced to actually meet the needs of that population group.
Thank you. Dr. Reilly, you've already touched on this fourth quadrant group. Is there anything that you wanted to add about the model of care?
No, simply to say I think that I agree with what Dan's saying, and I'm not suggesting at the moment that I think anyone's routinely in youth services doing that well, but it's clear that it does need to be integrated and that therefore in general it needs to be sitting with the mental health service with that responsibility, and that at the moment we're not taking up that particular challenge.
Okay, thank you. And Dr. Gruenert, is there anything else you wanted to add to that, that layer of model of care?
Well, by and large, I agree with the comments that Dan made and John made in terms of the need for a model like that. I think there are, some examples where it is an escalation point from drug and alcohol, and they're just starting to be trialled in Victoria with sort of an enhanced residential setting. I don't think they've quite got the capacity around mental health that are required to really deal with the severe end there. And I think you've got two challenges in that fourth quadrant in the most complex group. One of them is dealing with any initial and immediate needs around withdrawal, and where someone's drug and alcohol use is so out of control that it's physically dangerous and harmful for them, and it needs to be carefully managed in a way. And likewise in mental health, when someone's really unwell, the management of those symptoms and containment for the person's safety is really critical. But then we move quite into a different stage where, if we've got a severe drug and alcohol issue, that clearly this has been problematic for them for a very long time, and merely going through withdrawal, might have alleviated the initial concerns and symptoms and safety for that person, and you can do a whole lot of work with them. But unless all those underlying issues are dealt with in a very intensive way, you're not going to get resolution. So I think we do need to develop a much more nuanced response there that really has equal input from across drug and alcohol and mental health, and is an escalation point for the sector, because I think they'll be willing to take on a lot more in their own sectors to do the best they can if there is that backup of an escalation point.
Thank you. Professor Lubman has suggested in his witness statement that ideally integrated care should be provided in a single service setting to minimise any additional barriers to care. So the question is a single treatment setting required in all mental health settings? And Professor Lubman, can I invite you to respond first?
Yeah, thank you. I suppose my comments are largely related to an ideal state, and really reflect the issue that we shouldn't be segmenting and compartmentalising people's issues into a whole range of different issues where they need to seek treatment from multiple different treatment services and providers in different environments. The key thing is that we know that often when people present, they present with a whole host of issues, and they're looking for a solution from their treatment provider. And the challenge is often that we identify multiple problems that we identify in that individual, and that we, because of the way in which our system is designed, we tell the person that they actually need to seek help from multiple service providers rather than a single service provider. So the issue is more about the system response rather than what the individual's presenting with. And so I think the key principle that we all agree on is that we should make seeking treatment as easy as possible for the individual, that when an individual presents, that their needs are ideally met in a single setting. That might mean that we need to upskill, the workforce in those settings to be able to at base level, to be able to provide most of those persons' treatment needs. It might mean in some situations we might need to co-locate services and actually work together. The important thing to say here, though, is co-location doesn't necessarily equate to integrated care, because there's lots of examples where services co-locate but actually still don't work together. So it's more about how we commission services and the expectations of that commissioning and how we monitor what services are providing. It's about, at an organisational level, that the interagency partnerships and treatment philosophies and shared goals. And it's about at the service level, at the staffing level, how we work together with our colleagues in other fields to actually provide a much more seamless treatment response. So for us, the principle is really about ease of access, treating the people where they're at, not making the treatment more difficult by having them need to go to multiple services to receive that need. Obviously, you know, we work in an environment where we can't cover everyone's needs. There might be physical health issues, mental health issues, substance use issues, housing issues. You know, so it's going to be difficult to have all those co-located or in one setting. But you know, the principle I think that we need to work towards is that we make it as easy as possible for the consumer, and we have those capacities within services to meet those persons' needs, so that we can maximise their engagement and ensure they have the best possible holistic response.
Thank you. Dr. Reilly, can I turn to you?
Yes, look, I would agree. And I think that consumer choice can sometimes be an issue. And so there may well be circumstances where a consumer may prefer to see two separate providers for what they're considering as two separate issues. But that would be unlikely in most instances if the consumer is thinking that the person who they are seeing has the capacity to manage their problems in an integrated way. I think that, you know, I would see that as not being a likely scenario, but of course it might happen on occasion. And I would agree with what Dan's saying. I think that there are inevitably some boundary points. We can think that it would be good, for instance, for someone who's got a substance, say, you know, who may also need treatment for hepatitis C, for chronic pain, as well as for an opioid use disorder, and who has a severe depressive disorder that they're receiving treatment from. It's going to be very difficult for any one service provider to make sure that they're addressing each of those. There are, of course, going to be some boundaries. So it's really about trying to configure services in such a way that they are most generalist whilst still providing the appropriate levels of specialist care.
Dr. Gruenert?
Yeah, when I was speaking to some young people in preparation for this, some of them have said things like, my issues impact on lots of areas of my life, my housing, my family, my relationships. You know, there's drug and alcohol issues, there's mental health issues, but I don't see myself as complex. What's complex is the system and the things, the hoops and hurdles I have to jump through to try and get someone who can actually hold that picture of me together. I agree there's a tension between ensuring all systems are generalist enough that they can hold that picture, that they can do those assessments and identify things and see a person as a whole person, whilst not replicating every part of the system within, because there's some real value in having some specialist systems who are really key at what they do. I think the issue of choice is important too, and certainly we found it, whilst we have been able to provide some vocational services, for example, to some of our clients, they actually have a better experience when they engage with a specialist vocational service who can be with them for the long journey throughout their recovery and help them find, you know, employment over multiple occasions, rather than feeling dependent on us who got them through the key part of their journey. So sometimes there is a value in seeing a specialist, you know, sexual assault counsellor who really is at their peak of working on that particular issue. But it needs to be based on a foundation of generalist care, where the case management and the treatment planning and everything are put together in a way that incorporates and considers and understands that whole person, and can sequence some of these things with them or prioritise what you're going to work on, and they don't feel like they have to engage in so many different trusting relationships. So as a general rule, for most people, single setting is the ideal you're aiming for, but of course there's exceptions and boundaries to cross at times.
You know, can I just make one additional point? So I just wanted to give an example which I think is really helpful. So we've been fortunate to be able to trial a whole range of different integration models, over the past 10, 15 years. And the models that have the most success is when we're able to embed workers in other people's services and create models of care that actually work. So for example, we had a pilot project where we were able to put an alcohol and drug nurse in an inpatient mental health unit for 12 months. And so that position was supernumerary to the existing sort of mental health staff. And they were there bringing addiction expertise. So they were there to provide in-service training to the nurses. They were there every day so that they're there at handover to be able to ask the question around substance use. So it became much more familiar in the assessment and the management plan. They were able to handhold people in the system in terms of treatment of withdrawal within that setting. And they were able to facilitate referrals out of the system to the broader alcohol and drug system in which they work. And that model worked really well. We saw a massive increase in screening for substance use disorders, a greater confidence in workforce in terms of managing people with substance use disorders. We saw a greater number of people who actually had good withdrawal plans while they're in the inpatient setting and were actually linked to services. And then the funding ran out, and within 6 months, the service had returned back to what they were doing previously, in terms of not screening, not doing many withdrawal plans, not linking with services. So the issue is, and when we've had models where we just fund a service, for example, to provide an addiction nurse within the service setting, what inevitably happens because of the budget constraints and issues within systems is that if that position is only within that service and isn't linked, we don't get that external linkage to the other parts of the system. And then through budgetary constraints, what almost invariably happens is that person gets absorbed into the general pool of nursing so that it doesn't become a specialist position over time. So for me, there's really great examples of how we integrate services by actually embedding workers in each of the services. We did another project where we had mental health workers when I was working at Origin in my team, and we had them embedded within YSAS and another youth alcohol and drug service. Again, they were embedded, they actually worked there, they were providing mental health treatment to people who were presenting that service. So we trained up the alcohol and drug workforce to do screening, to identify, to build the capacity, and have a referral point for actual treatment. And that worked again really well, increasing people's confidence and capability in managing a whole range of risk issues that they previously were not happy to do and wanted to refer to the mental health system. So we were able to actually manage that within the system, increasing people's capability, and then the funding ran out and those people left and we went back to where we were. So there's really great models of embedding workforces in our respective systems to actually create that integration, to increase capability, to increase traffic and trust and ability to refer across the system. So there's really great models where we can do this, but it's important that we work in partnership and we build on those evidence-based principles.
And just quickly, other than funding, was there anything else needed to sustain those kind of models?
So I think, as I say in my submission witness statements, and we've done a whole range of work around what good integrated care looks like. And integrated care is at 4 different levels. It's at the commissioning level, it's at the organisational level, it's at the service level, and it's on the ground with clinicians. So funding is one component of that, but if there isn't a commissioning framework that says this is a priority for us and we're going to measure that, if there isn't an organisational priority that says we recognise that this is a really important way in which we need to provide good care to our client group or to our patient group, and we want to work in partnership with our other local providers, if there's not agreement at the service level that we want to do this in terms of best practice, and we have models of integrating that. So funding's obviously critical, but we have to have all those other elements in, because otherwise it becomes just an ad hoc sort of individual response that's not in any way systematized. So we have to think about the entire system and all those different elements to make sure that it remains a success and is not dependent on individual personalities.
Did anyone else want to comment on anything that Professor Lubman's just said before I move on?
Perhaps later.
Okay, thank you. Thank you. We were talking before about single setting care, and so the next question is are there viable alternatives to fully integrated or single setting care in certain mental health settings? So Dr. Reilly, perhaps if I turn to you first, are there viable alternatives?
Yeah, look, well, of course there are viable alternatives. I think along the lines, because in a sense what, when I'm talking integrated care, I guess what I'm saying is that a team or a clinician is providing that care fully within that, by that clinician or within that team. Now, then it comes down to, well, within, are you expecting that clinician, therefore, to have all of those skills, or are you expecting that it might be something that works across a perhaps wider multidisciplinary team? And I think if you go with the latter, then certainly it's possible for people to have portfolios of particular interests. And I think that the examples that Dan just gave are kind of examples of that, where you're perhaps suggesting that in a team, whether that's a community team or an inpatient type service, that perhaps someone's got a portfolio. I think that the challenge though then with that still becomes that there's always the risk that if it's not fully integrated, but that there are people that it's kind of compartmentalised to some degree, there is the risk that others still tend to see that as being someone else's responsibility rather than assuming full responsibility. And that means that in their individual clinical interactions in other contexts, perhaps that doesn't work. So I think that it is possible, but I'm just not, I would see that you'd have to be really clear how it's going to work, what the requirements will be, if you're going to separate it out and not have that as an expectation that all mental health clinicians should actually be capable of managing in an integrated way.
Okay, thank you. Dr. Gruenert, can I turn to you next?
If I pick up a point that Dan raised early on, that one of the most powerful tools we have in the work we do in the drug and alcohol sector, and I'd argue in many parts of the mental health sector, particularly the psychosocial end, is the capacity to engage with people and be there as a sort of non-judgmental, credible person. This is often one of the biggest issues and one of the biggest difficulties for many of the people seeking our help, because they've had their trust damaged on so many occasions and they've struggled with their relationship skills. And we know in sustainable recovery from both drug and alcohol and mental health issues that positive, strong relationships and relationship skills are one of the key predictors of long-term success. So if we're trying to assist someone who often comes with all sorts of issues, damaged relationships, difficulty in trusting, the biggest challenge is establishing a relationship with someone where they can build that trust and build those skills. And this is also why so many peer support programs work particularly well, because they can share the ideas and thoughts and go on that journey together with other people that have had similar experiences, at least as part of their treatment. So again, regardless of the model you're using, whether it's co-location, whether it's embedded staff from one service, whether it's a highly skilled generalist that's got the multiple skills, I think the aim is really trying to minimise the number of different people, or even if it's a multidisciplinary team, where there's multiple different specialities. Of course, you're going to have better specialists in a multidisciplinary team. And each one of them will be better at their particular thing than just one generalist. But we always come back to this point of trying to limit the number of people and different contact points that someone has to engage and develop that relationship with in order to receive their care, their understanding, their assessment, at least initially. So I think, I think all of us would agree that these are issues people have been struggling with for ages. I don't think there's a perfect solution just sitting there ready for us to go. People have tried many different ways of approaching this, but I think it is a fundamental that we need to limit the number of people they're having access to or that are delivering that care. And the more we can support that person or that team of people with help, the better, whatever the model looks like.
Okay, thank you. Professor Lubman, do you think there are viable alternatives to fully integrated or single setting care?
I mean, I think there's not much really to add to what Stefan and John have said. I mean, I think, the principle is there. I think we're a long way from that. I think there's steps along the path in terms of how we can get there. But I think, I think integrated, for me, it's not integrated care. For me, it's, just good care. So it's about how to provide good care, and the integration is really around, well, what are the different support systems around that we can build in to create a much more optimal experience. So in terms of providing good care, yeah, we should definitely be providing good care in every setting. How do we integrate some of the specialist services together to actually create a much better treatment experience? There's certainly lots of models out there that we can draw on, and I think there's a lot of literature out there of what does work. And I suppose it's around, I think one of my biggest frustrations in the system is that we don't recognise when we're not doing a good job. So when people are struggling in the system, we don't really have good mechanisms of escalation. I think it comes back to this again. So when somebody it's not working, the system, it's very difficult for the system to step back and ask, what is wrong with the system? It's very much, it's about the individual. So the individual isn't motivated, the individual isn't responding to treatment, the treatment's not working, the medication isn't working yet. But sometimes it's about the system not actually being the right system for that individual. And we don't really have mechanisms to step back and ask, how can we nuance the system, or what different system approaches can we take to actually meet the needs of that individual? And, we're often left having a very generic service model that we just plant everywhere. So for me, one of the biggest things out of this is how do we think about recognizing that different people need different things, and we need to work out how we provide the best quality response to the person for them. And we need to recognize when it's not working, and we need to work out how we escalate to different models that might be better. So for some people, we might say they might have severe mental illness, but actually they're going to do much better in some of the alcohol and drug spaces with the right support. Or they might be better in the mental health system with a bit of alcohol and drug support. I think we direct traffic based on what the services thinks best, not what the individual thinks best. And I think that's a challenge, I think, for all of us to think about how we design a system that actually best meets the needs of individuals and best gives them what they need to optimise their health.
Okay. And as the Chair said, the Commission is speaking directly with people with lived experience to understand their perspective. But in your experience, what are the benefits of an integrated experience at the front line for consumers? Dr. Gruenert, can I ask you that question first?
Oh, look, I think we've touched on many of the benefits already. I think for a consumer to have a single touch point, to tell their story once, to have who they are as a person and what they're struggling with understood without having to compartmentalise it is a much more satisfying and rewarding experience. And it's also rewarding for the staff when you can actually see people achieve success and make steps in their journey when it's done in that particular way. And I think the outcomes are typically better. But I think Dan's point is really, really critical. We employ a lot of staff with a lived experience in our services, and one of the biggest things we have to do during that orientation phase is to help them understand that what worked for them doesn't necessarily or isn't necessarily going to work for everyone else who accesses the system. So for some people it's a pharmacotherapy that was the thing. For some it was those peer support groups. For other people it was the sort of psychological strategies or repairing a relationship. And it's really important that we do have the diversity and we encourage and nurture that across our systems to allow that both the choice of the consumer, and often they make a lot of choices. Sometimes the system tries to feed them in one particular direction, but they often come with a clear idea of what they want or what they think will work for them. And if we have a system that does acknowledge that, then it's a much more satisfying experience for the consumers.
Dr. Reilly, is there anything that you have to add to that?
Perhaps just that I think Stefan highlighted before relationship, and if you've got integrated experience, then you've got a greater capacity then to focus on maybe building a relationship with a person who's going to actually be taking a more comprehensive and more holistic perspective rather than separating out and telling you to go off and see at least 2 different services. That obviously enables you to engage. I think it minimises, potentially at least, it minimises duplication and allows you therefore to have a more comprehensive whole perspective on that person from a service point of view, and I think that consumers can feel that if that's done well.
Thank you. Professor Lubman, is there anything that you want to add to this question?
Yeah, I mean, I think we've covered a lot of it, but I just want to emphasise what Stefan raised around staff. I mean, a lot of the time that we get involved in sort of working with services to look at complex kinds, which, as we've already heard, is less about the complexity of the individual, but the complexity of the system. Staff, are often very frustrated because they don't know what to do. They don't have the capability, the skills. They're often left with somebody who's not getting well. And, staff can feel very frustrated because they don't know what to do. And then there is a tendency to blame the individual, for that lack of response. So for me, I mean, working in this integrated space and having worked with a whole range of workforces in terms of building their capability and providing that level of support, I think one of the most remarkable things is to see the level of optimism and hope return to the workforce, and that then gets, dissipated, to clients and families. I think the most frustrating thing is if the staff and the service don't know what to do, that, from a client and family point of view, when they're coming to that service and they're getting a response which is essentially, the frustration of the service not knowing what to do, I think that's a terrible experience for clients and families. And families are struggling. They don't know what to do often with the substance use. They don't know how to respond. They're looking for professional advice around what to do. And if the service also doesn't know what to do, they don't know how to properly support the families to actually provide the best and optimal care to the individual. So an integrated response, is critical at so many levels, and it's critical really in terms of re-energizing the system, in terms of building its, hope. Really, hope is lost in a lot of the system because people don't know what to do and they feel stuck. So we want to engender a system that actually promotes hope. We've got to make sure that the staff themselves feel confident that they know what to do and that they have options available for them.
Okay. Finally, in terms of addressing people's needs, the question is a different approach to integrated care needed for young people? Professor Lubman, I might stay with you. In your view, is a different approach needed for young people?
I think at a broad level, it'd be fair to say no. I mean, I think good integrated care where we're meeting the person where they're at and we have the right level of support for them, I think is critical. Obviously, there's a number of youth relevant models because of developmental stage or age or how we better integrate families at that stage, I think might be key. But I think broadly, no, I don't think there is differences. There's differences obviously in the type of substances young people use, in how they might present, how they might engage, and we need to be relevant. We need to bring in developmentally relevant evidence-based strategies around that. But in terms of the principle of integrated care and access, I don't think there's much difference in terms of what we've been saying.
Thank you. Dr. Reilly, do you have a comment on the models for young people?
No, I'd echo what Dan said, and therefore the only comment would be that it's perhaps recognising that young people then are sometimes dealing with different service systems, sometimes related to how health sets up or mental health sets up, and that therefore if we're thinking about other aspects of culture and workforce, it's important to be as holistic as possible in our thinking, because it might be a different group to the ones that we're proposing to think about.
And Dr. Gruenert?
Echo those comments. No difference to the approach or broad philosophies. The way they're implemented can be completely different to make sure they they work with young people. The point I'd add to all of what's been said is for young people, it's critical to have engagement's critical, and you only get that with credible staff who can understand and I guess feedback that experience to the young people. And because without that engagement, you're not going to get the effective partnership approach and the motivation and compliance or the working together around the implementation of all the treatment goals and things that you've got. The second thing I think that's possibly in its implementation is slightly more of a challenge or different is the way we work with families alongside young people. Obviously, families are important for people anywhere across the spectrum, including with adults. You know, they're an untapped resource, and the service systems don't particularly integrate the work with families particularly well across the spectrum. It's particularly critical at young people. So much of the pathway that they're on can be alleviated or diverted if we can get the relationship with families. Now, that's a real challenge for many people working with young people who are often a younger age, because that engages well with young people. And therefore, they often don't have quite the experiences around parenting or working with families, and they often have a lack of confidence in doing that. So I think the family work is really critical with young people, but broadly the approaches are the same. It's just how they're implemented and nuanced in the youth models.
Okay.
Can I just echo Stefan's point? Because I think, I suppose one of the challenges we often see in some parts of the sector is, you know, obviously with young people, you know, and the strive for independence, you know, at a critical age, that some experienced staff that we see in youth services can misconstrue the independence as independence from family and supports, and there can be tensions in terms of, you know, how to best engage that family in providing that critical support setting around them. So the young person might say they don't want anything to do with their family, but we know from working with people that getting their family re-engaged and building those supports is critical for that person's long-term recovery. But if you're, as Stefan says, you know, one of the issues we'll come on to is around capability of workforces. But if you're an inexperienced worker who doesn't come and isn't trained in family-based approaches, that, you know, they can inadvertently make the situation worse by siding with the young person and actually working against the family rather than with the family. And I think, you know, that's really critical in terms of, you know, when we think about our models of care and when we think about the capability of the workforce, sometimes we underplay the important role and skill set around family-based practices.
And Dr. Gruenert and Professor Lubman, you both mentioned different engagement, young people engage differently. What does that mean in terms of providing care? How do you better engage young people then? Oh, sorry, Professor Lubman, could I turn to you first?
So I suppose often when we see people in the adult space, you know, we're seeing people who've struggled with problems for a long time and have had lots of reflections about what's going on for them, and in some ways more articulate around, you know, what their needs or what they're looking for. Often for a young person, there's a lack, you know, there's obviously a lack of life experience. And there's a lot of things going on for them that can be extremely bewildering and confusing, and it can be often, you know, it can often be difficult for them to articulate what they really need. And I think so. The big difference I think in young people is around how you meet the person where they're at, you know, particularly for the young person, and find some common ground and identify an issue that they want to work on. So it's about identifying the issues that they want to work on and being able to work on that. So for them, that might be something around studying or school or work or housing or Centrelink payments. The critical thing is it might not be working on their alcohol and drug or mental health issues in the first instance, because for them, that is not the priority that they see. So it's that flexibility to be able to build that relationship by identifying what are the 1 or 2 issues that they think are the priority that they need to work on. And by demonstrating that you can actually be helpful in that space and actually do something for them, that builds that level of trust that actually you might be a useful worker to work alongside, and that then allows that broader conversation to develop around those other issues that you're trying to target. So it's that flexibility to not just be focusing on the clinical response, which is important, because for that person, that might not be their priority and it might not be something they're ready to engage with. It's that ability to have that broader panacea to build that trust so that you can actually address the real issues that are underlying, where that young person is struggling.
Thank you. Dr. Gruenert, is there anything that you wanted to add to that?
Agree with Dan's comments, but I would add a couple of things. This is a real classic example of where there's a tension, and there's many parts of the system where it's finding the balance of the tension that works really well. And the tension I'm talking about is that we know sort of supportive counselling or aligning yourself with where someone's at is the best way to engage someone, but it doesn't necessarily bring about change. And we know the sort of psychoeducational things and setting boundaries and having a sort of challenging dialogue can be really effective in bringing change, but people lose engagement and they drop out of treatment, and that doesn't work either. So the best way this is done is where you have those two things in tension with each other. And we've all heard of examples of services where it's all about sport and recreation, rock climbing and fun stuff, hip hop, dance classes, whatever, spray painting. And if that's all it is, sure, people will come along, but there's nothing that's actually taken them to the next level. And vice versa, a service that's, based on a whole lot of evidence of the actual interventions and tools, if young people aren't getting there, then it's not effective either. So it's walking that line. And the one point I would make that we found most effective, it's not just with young people, but it's particularly there, the people most likely to engage someone and take them to the next level are the people with a lived experience who are just one step ahead of that journey. So if we can take someone who's been there fairly recently, who can understand where someone's at, but has moved through it, they are the best person to identify exactly what's going on for someone, use the right language for them. And so in some ways, asking us or asking me as an expert what's going to engage young people is probably not I can share my observations, but we got to ask young people. And I totally agree with Dan. We've got to start with what they want, what's their priority and their goals and their dreams to build that relationship. And over time, we need to then put the things in place that we know are going to bring about change. And at times when a young person is out of control, the voluntary system doesn't do that. And we see people cycle around, they're given lots of opportunities to engage, they simply don't. And I think there is some place for a non-voluntary front end to the system that, when people come out the other end, say they can acknowledge, I was out of control, I needed someone to pull me up. And I can see how I was going downhill in a particular direction, but at the time I couldn't see that. So it is a tension.
Thank you. Dr. Reilly, was there anything that you wanted to add to engaging young people?
Sorry, can you hear me still?
Yes, I can. Thank you.
Somehow I've muted everyone, it seems.
That's okay. I can hear you.
So I think that what I would say there is, in response just to what Stefan just said though, I agree, it would be great. It's just a bit difficult to see how you would govern that issue of the involuntary treatment at the front end for those problems. But yeah, fascinating to see.
Okay, thank you. The next topic is governance, and I'm just noticing the time, so I might give you a break now rather than break up the governance topic. So I'll give you all a break for 10 minutes and then we'll come back with the last 3 topics: governance, workforce capability and prioritising. Thank you very much. Thank you. The next topic is governance. So the first question is, how could Victoria integrate governance and policy of mental health and alcohol and drug services at a departmental level? Dr. Reilly, can I ask you that question first, please?
Sure. Look, I don't actually know how it might be done in Victoria because I'm not really familiar with how its Department of Health works. But clearly, it's all within a Department of Health. Departments of Health are configured in various ways, and of course, they do at times, with regard to governance, shift branches and divisions or whatever within them. So I think it's really the key issue is a clear decision at the level of the executive of the department and the minister that that's a policy position that the government and then the department wants to take forward, and that it's considered what are the issues associated with that. And I think if that happens, then it's actually a comparatively straightforward matter. The Queensland experience essentially was that I think it was more at a departmental level, but with obviously government approval. And I think the challenge, of course, then becomes one issue, particularly perhaps that alcohol and other drug services or alcohol and other drug policy relates to is perhaps more the prevention aspect, and that there are some larger issues that sit within health but outside more clinical service delivery policy. And so those challenges need to be considered in such a decision. So that's all I would say at this point.
And sorry, just to keep you for a second, from your perspective, what would the best model of integration look like in terms of governance and policy, maybe reflecting on what Queensland's done and what's worked well there?
Sure. Look, well, the Queensland decision was essentially that the clinical aspects of AOD policy needed to be linked with mental health policy and commissioning. And so they were connected up, and so it is a mental health, alcohol and other drugs branch. And I'm in that Chief Mental Health, Alcohol and Other Drugs Officer role, but that's comparatively new, and that links to the Chief Psychiatrist role. So I think the issue is that there is overarching governance across both mental health as well as alcohol and other drugs sitting at a particular point, because that creates the incentive then for integration at other levels, in my mind at least, and a clear understanding that's the case. You can then have separateness further down, because there are still a whole variety of things that will have to be dealt with separately. Certainly, even if there was a clear decision you wanted to integrate everything, you'd still have to do a very graduated process of changing commissioning and funding and the structures. And I'm not suggesting that, just saying it would require that kind of machinery change, and that would be difficult. So I think it's about how do you just make sure that at the policy and planning level that those things are considered always together rather than being completely separated out.
Okay, thank you. Professor Lubman, from your perspective, what would be the optimum model of integration of governance and policy at the departmental level?
Yeah, so I think as we've all been saying is that you cannot treat the mental health issue without treating the alcohol and drug issues. For me, that means a single department that oversees both the mental health and alcohol and drug sectors, and which oversees things like performance planning, quality, policy development. You know, it's critical that there's a shared vision around, you know, the mental health and well-being of Victorians. And, you know, as I say clearly in my submission, alcohol and drug issues, addiction is a mental health issue, so it needs to sit within that framing of a single department. So that's commissioning, oversight, performance and quality issues. I think the other point I want to make, though, that while that's at the commissioning and policy level, I'm also very clear that the systems need to be separate. I think, as we've already discussed, that there's marked differences in the populations that they serve, the treatment philosophies, the approaches they take. And so for me, while we have an oversight and a single governance within a single department, the systems themselves need to be commissioned and oversighted separately, but within that overarching framework. Because I think as I say in my witness statement, the examples obviously John can talk about Queensland, but certainly in other areas, the mental health system is such a much bigger beast than the alcohol and drug system. And, you know, obviously with a whole range of drivers around demand and around risk and around, you know, a whole range of other issues, the major risk is that the alcohol and drug system becomes subsumed within the broader mental health system. And it's really important that we keep them distinct and keep them separate because of their separate workforces and approaches and interventions and philosophies. The other thing to say about governance is that I've said in my witness statement is around the role of quality and safety. The Chief Psychiatrist's Office obviously plays a really important place in oversighting critical incidents and safety issues, and really plays a critical role of building the effectiveness and the safety of the system. That is currently absent in the alcohol and drug space. We don't have a mechanism at a system level for oversighting critical incidents and reviewing safety issues, identifying innovation and documenting that and evaluating and sharing that across the system. So there needs to be a mechanism like there is in Safer Care Victoria for the broader health network and within mental health, within the Chief Psychiatrist's Office, to actually look at system oversight, look at critical incidents, look at issues of quality and safety, ensure that we're continuing to improve and there's a culture of quality improvement and there's key lessons there to learn around how we approach different issues. I sit on a number of committees on the Chief Psychiatrist's Office around critical incidents, morbidity and mortality, complex cases. And, you know, 90% of all of them involve alcohol and drug issues. And yet I'm the sole representative from the whole system. And, you know, what constantly comes up is issues in terms of system integration, issues to do with capability, issues to do with monitoring and quality indicators. And so there's, you know, a really important opportunity to bring that quality and safety component within the governance structure so that we can ensure that we continue to build the effectiveness and efficiency and safety of the system.
Thank you. And Dr. Gruenert, from your perspective, what would the optimal model of integration look like at the governance and policy level?
Now, I think this is a really interesting and difficult area, and it's probably the one that we have had the most struggle even as a panel, and probably areas of disagreement around. I would agree with everything Dan has said around the potential for integration at the departmental level, and I think in theory that should work. But I'm less convinced, and I'm less convinced because history internationally and history from my colleagues in New South Wales and Queensland continually tell me of its failings, and that may be as much in the implementation as in the actual, you know, the intention. So I think in theory there should be the capacity for integration under a minister, under a exec at the department, as John was discussing, that has responsibility for both those areas, and that they're integrated in a way that has a shared vision, and where particularly the quality, as Dan was saying, the quality mechanisms and processes that exist in mental health which don't in drug and alcohol could really enhance the services and the systems, and the planning happens together. The issue for me is, fortunately in Victoria we have a Department of Health and Human Services, and I think the Human Services part of the department is a really important part to play in the treatment of people with both mental health and alcohol and other drug issues when you're looking across the whole spectrum of that. And so one of the criticisms about the way it's often done in the departments is that there's not a broad enough perspective. It can take a sort of pure medical or psychiatric role at the expense of the lived experience and psychology and other things. Now, if you've got someone who can really practice or does understand holistic medicine and the broad, you know, that ideal, then I think that that definitely will improve the way the governance is done. but often that's not done, and it's tokenistic. And I think the point Dan made around the size difference between the two departments, or even if they're distinct areas within a sort of an integrated, even at the department level, they can get swamped. And that again has been the experience of colleagues in other states, where the policies often just developed in mental health, and it's, you know, AOD's consultation feels tokenistic, or you're always trying to fit a mental health policy into a drug and alcohol setting. And if I could use an analogy to describe what often happens, I talk about clothing. So we could all agree that, you know, tops and bottoms that we wear are important. They're both clothes. Most people tend to try and integrate their clothing between the top and the bottom, sometimes the style, the colour, or for a particular climate. My kids are always insist on only having shorts on the bottom so they can play sport and it's fit for purpose, whilst they'll wear some pretty warm tops. And so the choice around what people want in those areas is different. But no matter what you do to a top, you can't stretch it or cut it or squeeze it to suddenly become shorts or a pair of pants. And it's even worse if the emphasis of the top you're wearing is just a winter coat and a jacket. And I'm thinking of the sort of clinical tertiary part of the mental health system, trying to turn that into a pair of shorts. And so we really need to make sure that the responses are fit for purpose, and that the thinking, and even on policy development, it isn't tokenistic, and it has a broad representation to make sure that, yes, we're dealing with the quality of the clothes. You know, we want good shorts, but we don't need ski pants for someone who just wants shorts. They just need to be good quality shorts. And if they tear or rip, we want to make sure they're built of the same quality of the fabric of the top, and that we're thinking about their design with similar processes and ways, but we're not trying to refit them. And that's, in my experience, what often happens in the implementation. So I agree in theory. I'm less convinced as having seen it done well.
Okay.
Could I just comment? Sorry.
Of course, Riley.
That's because, as Stefan said, it's probably the area where we have the most disagreement. So I guess just to highlight, I think there's always challenges with regard to where you draw a line about how things are integrated. So there's no question, there's no right way to do that. It's about what's going to work most effectively in a particular scenario and who's prepared to push that. There's no question that AOD services are going to feel they're the small brother if they are integrated within a wider mental health service system that's larger. But I also think that there's lots of benefits to be gained from that as well, which I accept do require though good implementation, effective implementation of that, whilst looking after those interests. And I think though we also need to think, is it really such a unified mental health sector? There's marked variation with regard to, for instance, the way in which child and youth services or perinatal services or some older person services or specialised eating disorder services work within a health department and within a mental health department or branch. And I don't think that seeing AOD as a kind of subspecialty area within such a wider, more integrated mental health alcohol other drug branch is necessarily all that different. I think also Stefan highlights there are still issues with regard to what's perhaps more clinical healthcare as opposed to non-government led healthcare, and there's no question that departments are doing funding out to different types of services. And again, we've probably brought those together, and we haven't sort of come out always with the specifics of that. So there's no question there's challenges, and I don't think there's any absolute way to do those things.
Dr. Reilly, just to stay with you, in terms of the potential adverse impacts for the alcohol and drug sector being overwhelmed by the mental health sector, what kinds of things has Queensland done to kind of guard against them and maintain the position of the alcohol and drug sector?
Sure. So look, I think the issue is perhaps having clear responsibility for that sitting with an executive who's got that responsibility, where there's a recognition that that's really important. that is that looking after the integrated alcohol and other drug services is important, and I wouldn't necessarily disagree in what Stefan's saying, that Queensland's done that extremely well, but I think that's something that we're continuing to look at, and once that's consolidated, that change, then I think that helps to highlight that this is an ongoing need to be looking after the AOG service system in the same way. I think the only other thing I would say, which I said previously, is that in Queensland, we've obviously got fairly structured hospital and health services as our local health networks. There's only 16 of those, and they are independent. That's where the funding goes out to, and each of those has their responsibility for both their mental health and alcohol and other drug services being integrated under an executive director or equivalent. Obviously, there's a chief executive and a board. They also have the responsibility for ensuring that AOD services are being looked after within their HHS in the same way as mental health services. So I don't think it's just a departmental issue, but that then raises the issue of linkages with PHNs and then the commissioning of NGOs. And there's no question that in that regard, because of the way in which AOD services are structured, NGOs, there's not that sense of a kind of area-based approach to quite the same level that there is historically in mental health services, at least in Queensland. So I think that there are a lot of aspects of that question, a lot of things that need to be considered, and a recognition, and I believe it might be more the case in Victoria, that perhaps there's a misalignment and it's difficult to get planning to cohere across LHNs, mental health services, AOD services, both clinically as well as with regard to non-government organisations being commissioned. And given that you've had a fairly different service system over time, perhaps Queensland's, it's no question that there's quite a challenge with trying to make such changes. And my observation over time has been that's been quite a significant challenge purely for the mental health services. If you're then going to also try and align AOD services up on that checkerboard, then obviously it brings a significant additional complexity.
Thank you.
One point.
Of course, Professor Lubman.
Very quickly, just echoing what people have said. I mean, I think one of the challenges I think that's come up during COVID. I mean, I think COVID has been really a great illustration of what works and what doesn't work. So what really happened during COVID was what we saw was the mental health system sitting within a part of the department thinks of it as a system, was able to step up and create a whole range of responses that recognise what the system was and recognise the different components of the system. The alcohol and drugs system at the moment sits within the community portfolio of the Department of Health and Human Services, alongside community health centres, paediatrics, dentistry, opticians, all the other parts of, I suppose, other industries that actually don't work as a system. They're all independent, essentially independent businesses that sort of provide services but don't work. There's no sort of comprehension of that of a service system and how the different parts of the service system operate. And I think that became really evident during COVID, that while the sector wanted to mobilise and think more from a sector perspective, the structures in place, because of where it sat within the department, was not able to move as it could have, as it did in other parts of the health system. And I think for us, the issue in terms of commissioning and where the benefits would lie, sitting more in that mental health space, is thinking about service models. So at the moment, the way that services commissioned in the alcohol and drug space are as widgets, that are agnostic to service models. A good example of that is an area that we're working on together is around the issue, for example, of withdrawals, residential services. So we have detox services across Victoria that are funded, but each of those services operate in very different ways, and there's strengths in that, but that is not through a process of being planned, that we have these planned different services with different staffing profiles, different models of care, different entry criteria. That's not planned from a system point of view, that's just how they evolve. And yet we expect people to try and navigate that system and understand what that system is without any sort of system design or planning. So for us, I think, particularly in the alcohol and drug space, we would really welcome sitting in a department that had a broader thinking around service and system design to think about what the multiple needs of different client groups and families actually are, and how we actually configure the system to build on the strengths within the system, rather than it being an ad hoc system where it's, you know, essentially, you know, a coin toss around what the response is going to be where you present.
Could I just make an additional comment?
Yes.
And I guess just to follow on from Dan's point, so perhaps to highlight that, is that because in Queensland we've been trying to plan using the National Mental Health Services Planning Framework for mental health services, and have seen the benefits of being able to do that so that we get greater consistency across the state. I think that because we've got a combined branch, integrated branch, so the same people are responsible for planning of AOD services as for mental health services, and they've been taking the lead in trying to set the DASPM, the Drug and Alcohol Service Planning Model, up in a sense, so to catch that up so that it's going to work in a similar kind of way to the National Mental Health Service Planning Framework in Queensland. So I think that that's an example of the benefit of the integration, of recognising that this is something that mental health's doing that actually drug and alcohol services would benefit from, and where I think that will also add the capacity then to start having those two aspects talking together. And just with regard to Dan's specific example, because we're an integrated branch, because we've got clinical services within our HHSs, AOD clinical services, we essentially were able to address alcohol and other drug issues, at least for the HHSs, in exactly the same meeting structure as we were doing. It was mental health, alcohol, and drugs. It was completely integrated. We were considering opioid-related issues at the same time as we were considering aspects of clozapine, for instance. We did have some separate meetings with regard to AOD, just to sort of hone in on those more specifically, but there were certainly lots of advantages for us in being able to do that.
Just in terms of this integration of governance and policy, and Professor Lubman, your comment that the AOD sector is much smaller and can be swamped, what are some of the adverse impacts that integration at that level could have on the AOD sector, and what could be done to address those adverse impacts? So Professor Lubman, I might ask that question to you first.
I mean, I think, you know, what we've all touched on is this issue around in some ways, homogenization of processes and policies and pathways and clinical care. I mean, that's the biggest risk, is that having worked within an alcohol and drug service, within a mental health, under a mental health director, you know, what became really clearly evident is that mental health colleagues didn't really understand what we did or how we operate. And, you know, and because they're managing a large mental health program, you know, they don't have the time, you know, or focus to be able to understand those nuances in the system. And so what we saw time and time again was you know, a policy was developed in the mental health program. It was then sent over and said, well, this is going to be applicable across the whole mental health and alcohol and drug system. And so things that we were not funded for or couldn't implement were endorsed as policy documents. So that relates to anything from, you know, and obviously sometimes these are relevant or not, but relates to issues around residential settings, around, you know, mental health has very different focus around ligature points and the way in which, you know, safety of those settings, which are very different to some alcohol and drug settings, which are more recovery and community focused. Differences in terms of risk profiles. So, for example, you know, because mental health programs very much focus on risk and suicidal risk and homicidal risk, there was mandating of questions and approaches that we had to put in as some of the first questions were when we see people, which sort of goes against all the things that we talked about before in terms of treatment philosophy. So rather than understanding that we have different treatment models and treatment philosophies in different ways, different populations, different approaches, there was this sort of, in some ways, bulldozer approach of, you know, we're developing something in the larger mental health program. You guys are essentially like a mental health program, so we're just going to roll it out to you guys as well. without understanding that that actually has negative impacts for the treatment models and the approaches that we take. So that's a very concrete example of my experience of that, and the challenges that I had to spend most of my time educating my mental health colleagues around why this wasn't a good idea and why we had to reverse it, rather than spending time focusing on helping clients and families. And I think that's the big issue. The big issue is that, you know, while they are integrated, they are different models, and we need to be very careful that the evidence base and what works in this system isn't steamrolled, you know, to fit in with the larger machinery of the mental health, public mental health apparatus.
Okay. Dr. Gruenert, can I ask you, what do you think is some of the adverse impacts and what could be done to ameliorate against those?
Yeah, I agree 100% with Dan there, that we can all see the benefits of bringing those systems approach and the additional resources and benefits to the drug and alcohol system. But I think one of the tensions and the issues the commissioners are going to be struggling with here is the resources involved and required and available, and working within those resources. And I think the biggest adverse impact would be to completely lose some of the efficiencies that exist within the drug treatment system by inadvertently putting quality and risk mechanisms and compliance things that just increase the overheads and the work required where it's actually not fit for purpose and it isn't required, and it'll just increase the cost of services in some areas. So I think, as Dan said, there's so many examples where a policy or thing has been developed. You know, the residential facility guidelines have come from mental health, and they thought with a few tweaks this could be made to fit drug and alcohol, but it's a completely different model. We don't need nurse stations with observations around people's bedrooms and things. You know, the bedrooms they spend so little time there that they need to be on the floor participating in the program. There was a recent example during COVID where there's a great Telstra initiative of giving out mobile phones and SIM cards and computers so people can engage in telehealth. And they developed guidelines in mental health. We're just going to roll it out across drug and alcohol. And we said, wait a minute, you want to give out all of this stuff and you expect it all returned at the end. Who's going to be responsible if it's not returned, if it's sold off and hocked? Or, just things that hadn't been thought about that really need to be, you know, frameworks and things that need to be built from the ground up from drug and alcohol, not just a tweak to mental health. And I think the last point for me is, well, the last 2 points. The drug treatment sector has had a lot of flexibility to innovate, and whilst the lack of governance and rigorous guidelines and things have often been an issue and can be improved, they have allowed a very nimble, quick system to adapt to things. So when COVID came along, the services moved to telehealth and phone-based support really quickly, and they were able to do some quick consultations to make sure there was new guidelines and resources from Turning Point and others in place to support that. Rather than building incredibly onerous clinical governance systems that would have taken a lot longer to roll out. And the second issue that's unique to the drug and alcohol sector, I think, relates to issues of criminality and the sensitivity of some of the issues in drug and alcohol politically. And it's always been a really strong point that to have people with strong advocacy, we've had to work really long and hard to get evidence-based programs funded in drug treatment, rather than be at the whims of what individuals think will work in drug treatment, whether that's community or members of parliament. And we need really strong advocates in the department that can push those models and aren't concerned and nervous that there's an election coming up, so we can't talk about whether it's, you know, decriminalisation or pill testing or harm reduction measures in prisons or a whole range of other things. We need a unit that has the strength and sufficient size, you know, not just be 5% of a department and does get steamrolled. So I think if there are mechanisms that can be put in place that ensure the processes really do build things from the ground up within drug and alcohol, as much as they're commenting on mental health things, and that ensures some efficiency in the system, and we're not putting unnecessarily layers on top of services that are suitable for, you know, clinical and tertiary end of the spectrum, but not for some of the psychosocial supports, then there's a chance this could work.
Thank you. Dr. Reilly, I feel like I've already asked you this question in relation to Queensland, but was there anything else you wanted to say in response?
Well, just a quick comment, Stefan, with regard to COVID and, you know, the mental health service creating massive governance models that would take a long time. I'm not aware what they were, that I certainly wasn't involved in such things that I know of. Yeah, I think the only other comment that I would make is some of the concerns, and I understand the concerns completely, don't disagree. I think, though, they also stem from a very separate service system, because they're all really about saying the mental health service system doesn't understand us, so we need to stay separate. I accept that. That's a way to approach it. I think the problem is, though, when we're talking about all of those issues, they can change if the mental health service system actually sees that AOD services are a core part of mental health services. The problem at the moment is, as Dan and Stefan have highlighted, is that that's not the way people think. And I agree that it's not possible to just change like that. So therefore there is a challenge with regard to, even if you were to say let's integrate, how you would do that, how you would protect that along the lines that I was talking about before. So I think that's how any adverse impacts would have to be addressed. And what you'd have to do is to have, you know, some a good kind of ring fencing of AOD and monitoring, and a gradual development of knowledge and skills that works across the wider service system, were that to be contemplated.
Yeah, and can I just add, I know this relates, we can expand on it later when we talk about the addiction medical specialists, but I think that is a big, huge gap. So, I mean, the comment I made before, when I sit on a lot of the chief psychiatrists' committees around morbidity, mortality and complex care, is because, unfortunately, I sit on those because there aren't many of me in Victoria. And so, you know, one of the issues is, you know, if we're trying to integrate alcohol and drug with mental health, you know, the reality is professional groups talk to professional groups. And so I get invited to so many, when we talk about alcohol and drug, I get invited all the time. And that's because, unfortunately, there's only very few of me available. And that's the tragedy in Victoria, that we don't have a breadth of addiction medical expertise that can work with our colleagues in in the mental health space to actually advocate for what's needed, to actually help build knowledge and clinical systems and expertise. And I think without that, you know, there's that whole missing gap in terms of a workforce that can communicate and link and build confidence in their colleagues.
I'm going to turn straight to workforce capability and the addiction specialist issue and stay with you, Professor Lubman. Are you able to articulate very briefly why there is this gap of 20 years of lack of addiction specialists in Victoria, and then move swiftly on to what's needed to increase the number of addiction specialists?
So thank you. So I've tried to articulate in the witness statement sort of I suppose, how we got here, and how we got here was really...
Sorry to interrupt you. Sorry, Professor Lubman, not the how, the why. Do you know the why? Why we, like,
yeah,
I know that there's...
How is the why? I know
okay.
How and why is integrated, because, you know, why is because, you know, an unintended consequence of deinstitutionalisation was the failure to recognise the need for a clinical addiction stream as part of service delivery in Victoria. And so, you know, there was a misunderstanding at that time, and that sort of failure and essentially unintended consequence of a policy decision has meant for the last 20 years we haven't had a systematised clinical addiction stream in Victoria, which a byproduct of that has been is there hasn't been an opportunity for medical, nursing and allied health professionals to actually train within those settings, within addiction settings, to actually get the clinical expertise and capabilities. It happens essentially by random and, you know, in an ad hoc basis rather than as part of a thought out system. So we have a whole generation of health professionals who know nothing about addiction, and in fact know as much about addiction from the Herald Sun as they do from their undergraduate curricula. And that explains why we have such huge amounts of stigma and discrimination that you would have heard from consumers throughout the Royal Commission process. We have a whole generation of health professionals who really don't know what to do. And that's not just in the mental health space, but includes in primary care. And that is a critical issue because we're seeing a whole generation of GPs who trained in the old system starting to retire, and they are the backbone of opiate prescribing in Victoria. And in the next 5 to 10 years, we're going to have we're going to hit a major catastrophe in terms of prescribing around opiates if we don't do something to fill that gap. So that's how we got there from an unintended consequence of a policy decision. Why we're in this position is because we don't have a career pathway, funded positions, and because we don't have, if we look at all the senior positions in mental health, clinical, mental health, a lot of those positions are also joint academic positions, which allows in-reach into the university system to train undergraduates, both in medicine, nursing, allied health, in terms of mental health. Because we don't have that senior clinical addiction stream, we don't have senior staff in those medical, nursing, allied health positions with academic positions. So we have no presence on undergraduate, postgraduate curricula. So there's a huge gap here that we need to fill, because otherwise, no matter what we do in this space, no matter how much we talk about integration, if we don't have a senior clinical addiction workforce in place, we're never going to address this issue of, the poor treatment of people with addiction and addiction with comorbid mental health issues. And it's always been a surprise to me that how the department, how, not this department, but how the thinking has been that, for a clearly, a clear health problem, that the health department can say that we don't need medical specialists to oversee, treatment for those with most complex needs. It's akin to saying in the hospital system, in the mental health system, we should defund all psychiatrists and clinical specialists, and they should use NBS items if they need a specialist opinion. So, there's a huge discrepancy between what we see in health and mental health, and that discrepancy, I think, speaks to the discrimination and stigma we see for this population group.
And so in terms of rectifying the number of addiction specialists, you've mentioned career pathways. What needs to be done to increase the number of specialists, and what kinds of organisations need to be involved?
Yeah, so I just wanted to flag for the Commission that we've been working for a couple of years now with the department in terms of an addiction medicine training workforce program. So we've been able to secure positions within the College of Psychiatrists and the College of Physicians to create a coordinated training for addiction positions in Victoria. So we've got a training program and a couple of coordinators of training, which is fantastic. And despite having coordinators of training, the biggest issue we have is we don't actually have many a clear strategy around funding training positions. So there's an issue around funding of training positions. There's an issue about accreditation of supervisors. So we don't actually have many funded addiction specialists in Victoria who can actually oversee trainees and provide that specialist pathway. And it's a very hard sell. I mean, John will be able to talk about this because one of his key roles was around overseeing training for addiction psychiatry across Australia and New Zealand. But we have a lot of very interested trainees, but the problem is there's no job at the end of it. Why would anyone want to put their hand up to do that job? So we need to actually have a career pathway where we have training positions, accredited placements, and actually a job at the end of it. So we need to have publicly funded addiction specialist positions and a model that actually speaks to where they sit in the system of care.
Thank you. Dr. Reilly, do you have views on what can be done to increase the number of addiction specialists in Victoria?
Well, I think as I generally support what Dan said, clearly there need to be positions for medical addiction specialists. I think that issue of training is vital. And I think that coming back to it from the co-occurring substance use and other mental health disorders focus, then as I've highlighted in my submission, I turned into subspecialists and generalist specialists along the lines of the UK paper. And I do think that we have to train all psychiatrists as being generalist specialists in going across all of psychiatry, which includes addiction. That doesn't mean that they're at that level of the addiction subspecialist, whether they're an addiction psychiatrist or an addiction medicine specialist, but I think that's what we need to be thinking. And so therefore what we have to be thinking is, what are the ways we create training positions, certainly within subspecialist addiction services, but also how do we emphasise that, of course, we've got enormous prevalence of comorbid substance use disorders within our training services that all of our psychiatry trainees are going through, and we need to ensure that, in fact, we seize those training opportunities, which at the moment we don't, because people don't actually know what are good models of care. They're not identifying, they're not assessing, and they're not treating for co-occurring substance use. And if we did that, we would certainly be building the capacity. But to do that, we have to actually be able to start that process off. And because we don't have that core group of addiction subspecialists, and because we don't have that mindset, at the moment we can't. So we go into much more detail, but that's probably the best thing at the moment.
Okay, thank you. Dr. Gruenert, do you have views on what can be done to increase the number of addiction specialists?
Yeah, look, John and Dan are the experts in this particular area, and I defer to them of the particular pathways, but I will add two things. One, we're talking about a long-term, I guess, time frame in order to achieve this from where we are in Victoria, and we clearly need some things in the interim to get us there. And I think if we are to achieve the sort of capacity in the mental health system, we definitely need some input from addiction specialists there. The key point I'd make is we need to go beyond. So addiction medicine is a massive gap in the Victorian AOD system, and I think that's impacting on the integration of care for people with mental health issues. But we've certainly got a lack of pathways and pipelines for a senior workforce across all sorts of disciplines in drug treatment. And I think we also need to have a strategy that, because as Dan says, people do talk to their peers. So we need it at all levels, and from, you know, social work, nursing, psychiatry, medicine, GPs, and psychology, all the way through the system. And the second point I make really relates to workforce development. We know that simply study theoretical programs don't develop a capable workforce, and what we need is really a lot of on-the-job training. And there's really good models and mechanisms in medicine and health and you know, in other disciplines for placements where people can learn on the job with proper supervision and support, including, you know, staff from mental health coming and doing rotations through drug and alcohol services at various levels to help build that capacity, which just simply aren't there. And we know that that's the best way to break down stigma. We have lots of graduates who, even if they've done some mental health or some addiction, which is pretty rare in any university degree, the minute they confronted with someone, particularly if they're intoxicated or in a crisis, the stigma and all their systems go into defence alert mode. So they need to be able to have real relationships with consumers in a variety of settings to build up that confidence and to understand people in a way that breaks down those barriers. So the models of workforce development have to be embedded in services, and they have to lead to some funded positions, as Dan said, out the other end. And that applies across all the disciplines. But I totally agree there's a real gap in addiction medicine, but we're talking multiple years to start filling that. But we can start the rotations and the practices you know, as soon as possible to make the most of the people we do have in the system before they retire.
Okay,
and so I do just have to jump in though to say it's not just addiction medicine, but it's also addiction psychiatry. Because unfortunately that does separate out, and that's actually a problem in a lot of documents. So I understand Stefan not meaning that, but that's actually part of the problem. So I just need to be clear about that.
Agreed.
Okay. I do want to ask about the increasing the workforce generally. Dr. Gruenert, I might go to the others and then come back to you to see if there's anything further you want to add. Dr. Reilly, perhaps I'll ask this to you directly first. How do we increase the capacity of the workforce generally? So we've talked about addiction specialists, acknowledging that there's addiction psychiatrists and addiction medicine specialists. So the capacity of the workforce beyond them to address co-occurring mental illness and substance use issues?
I think, as we discussed originally, Fiona, the issue there is, I do think that maybe being medically centric, but I think it's reasonable to start with the medical specialist, because if they lack capacity, then it's very difficult for anyone else to come in over the top. Not saying impossible, but it makes it much harder because they are often taking some significant clinical decisions. So I think that if we've got that, then what we have got is that people are, in fact, as Stefan said, learning on the job. If we can train our psychiatrists in the mental health service system to actually be competent and capable in managing co-occurring substance use disorders, that helps to pull other people along. I think the other issue is then trying to get more crossover, that people do have those training experiences at all levels of training. And whilst we've got separate service systems, that's much harder. I think that if the service systems are more integrated, there's greater capacity to start to make those links and connections, but clearly that's still very difficult at this point.
Thank you. Professor Lubman, do you have views on how we can increase the capacity of the workforce to deal with co-occurring issues?
I mean, I think a couple of things to say. I mean, I think if we go back 10, 20 years, we had the establishment of the Victorian Dual Diagnosis Initiative, which at the time I think was a brilliant initiative because it was really increasing people's awareness of the interrelationship between mental health and alcohol and drug issues. And I think, for its time, it was a great initiative. And it was very successful in increasing awareness. The challenge with that initiative is that there wasn't, the strategy for what it was trying to achieve became outdated, and there wasn't governance over what the initiative was actually trying to achieve. And the backbone of that initiative became didactic training, which we know in workforce models is not an effective way of changing practice. And I think I speak for all of us when we say that, if we want to increase the capability of the workforce, we actually have to do competency-based training. We have to actually, the whole model of working in the field of health and medicine is around, seeing something, doing something, teaching something. That does not, if I want to teach somebody how to deliver a baby, I do not do a half-an-hour workshop on the theoretical ideas of delivering a baby and then send people out to deliver babies. I think that's, because that's easy to do and because we can do it at a mass level, unfortunately that's been the sort of the way in which training has been delivered in this space. Let's do a couple of one-day workshops and then we'll see change. I think what John's referred to is that we've had a number of examples where we've worked with different professional groups to increase their capacity, but then they go into a mental health service where the consultant psychiatrist is not interested in substance use, doesn't want to know about it. And so there's no mechanism to actually provide evidence-based alcohol and drug intervention in that setting because the medical leadership in that team does not feel capable or does not see it as a priority. So there is something about prioritizing that medical workforce. One of the initiatives that we were able to get funded a couple of years ago was to identify, and building on what John said, there are a number of consultants across Victoria who recognise that they need to increase their skill mix in the treatment of addiction. And we were able to get some funding from the department to actually have that person come and sit with us one day a week for 18 months to work in an opiate pharmacotherapy clinic, to see a whole range of people with co-occurring disorders, become skilled in that space. And they were able to return to their area mental health service and adopt the lead role as a portfolio holder for addiction and co-occurring substance use disorders in their mental health program. So there are opportunities for looking at how we create not necessarily just addiction specialist expertise, but how we build the capabilities of medical leadership in the different area services so that we can have people who are very skilled in this space, who want to upskill their colleagues and want to create models of care that actually work. So for me, it's very much about competency models, opportunities to work under supervision and to actually see what, practice what's happening under that supervision and to feel capable of then being able to share that knowledge with their colleagues. I just want to also echo what Stefan says when we talk about when we talk about the workforce, I mean, I think unfortunately what we see very much strongly in the alcohol and drug space is that a lot of the funding models mean that when we do get very highly skilled senior nursing and allied health professionals, there's not a career pathway for them in the alcohol and drug space because we don't have this sort of tertiary clinical addiction stream. What that means is then, you know, we spend a lot of time training up these really experienced nurses and allied health staff, and they end up moving into mental health because they pay better and not necessarily into roles that actually play to their strengths in terms of, you know, knowledge and expertise in the alcohol and drug space. So when we're thinking about, you know, this area of a tertiary clinical addiction stream, it is about not just the career pathway for doctors and having clear specialists in this space to support the broader mental health system, but it's also being able to retain specialists in nursing, allied health, to be able to continue to provide their expertise both within the sector and to be able to in-reach into other sectors and to work with their colleagues.
Thank you. Dr. Gruenert, was there anything you wanted to add in terms of developing workforce capability?
I think the issues have been pretty well covered. The only point I would add is that for this to work, if we're really serious about changing both the culture within drug and alcohol and mental health and delivering better care for people, we need a sustainable strategy. So one-off little injections have never worked because we always have turnover of our workforce. And if we want our investment in the area to really have a lasting and a real benefit, it does need some level of sustaining over time. And that includes, I think is why I'm so keen on some sort of dedicated funded positions, because I'm sympathetic to the arguments that Dan's put forward around, you know, sometimes when resources are tight, you know, money can get lost in a pool and it'll get used in other ways. So in including some of those outreach of your staff models, so they keep some specialist connection to their sector, but are seen as a dedicated role to support people in the other sector. And that's worked really well across child and family support in drug treatment and family violence, where you've got some specialist funded positions that really do build the capacity. We don't, though, just want people that are sort of in training roles. They really need to be on the ground, you know, with the capacity to work and do some clinical work as well across those disciplines. But I think the rest of the issues are being well covered.
Okay, thank you. I'm going to turn to the final question and then hand over to the commissioners, which is on the issue of prioritising. And Dr. Gruenert, I might stay with you, so ask you to respond first. In the context of this Royal Commission into Victoria's mental health system and considering the reality of rationed resources for Victorians with mental illness and substance use issues, what are the priorities for the allocation of resources?
So the two priorities for me would be to firstly have specialist funded positions within both sectors that can ensure that when someone seeks help and support, they can get a response from that sector that provides, you know, holistic care, whether we call it integrated or not, that meets their needs and prevents the need for them to be referred elsewhere in the most cases. So the majority of people can be supported within each sector without having to swamp or overwhelm or be shunted back and forth between sectors. So some dedicated specialist positions. And the second one is I do agree there's a gap in the specialist addiction psychiatry and medicine that will support you know, the decision making and the governance and the training across the board. I just have some anxiety that becomes the dominant framework if the focus is only there, and that we don't value, you know, peer workers, people with lived experience, social work across, and psychology, nursing across the whole spectrum.
Okay, thank you. Dr. Reilly, can I turn to you and ask what would be your priorities for the allocation of resources?
Sure. So I think I'm not clear whether Victoria's mental health service system, along the lines that I was saying with our dual diagnosis toolkit and the 4 quadrants, at least there's a clear statement. I'm not saying necessarily followed in Queensland, but at least a clear statement that in quadrant 4, there is an expectation of co-occurring substance use disorders being looked after by the mental health service. I don't know if that's the case in Victoria. There may be a document that says that, but it's not clear to me. So I think that policy issue doesn't cost a cent. It costs some thinking, though, and a decision that would be required. And obviously that might lead on to issues about capacity, but I think that's the first step. After that, then it's really about, well, if that's what's required and if that's what the department says, how is that being implemented? Because the message seems to be, well, it's not being implemented at the moment effectively. And if that's the case, then how would you do that? And I guess I've said in my submission, really that then comes down to having a clear model around that expectation that mental health services do provide treatment for co-occurring substance use disorders. And to do that, my simplest approach would still be, and this is without fund, I agree completely. Dan has already highlighted that we'd need to develop that specialist addiction capacity, but if you didn't have any funds, then I would still be saying that it should be possible to get training for psychiatry trainees to all have a mandatory experience in addiction, and doing that, the simplest way I can see at the moment is still the consultation liaison term should be integrated, but there should be a greater focus on that co-occurring substance use disorder within all of their training. That's absolutely cut back to nothing, just saying that's what I would start with.
Okay, thank you, Dr. Reilly. Professor Lubman, what do you see as the priorities for the allocation of resources?
Yeah, I think as I've said throughout my witness statement, I think the big missing gap is this clinical addiction stream that's been missing since deinstitutionalisation. For me, that's a stream that's multidisciplinary, so that's not just addictions medical specialists, but also nursing, allied health, senior peer navigators, a multidisciplinary team that I would see a series of clinical hubs across Victoria that are in reach, both into the mental health system, into the general hospital system, into the alcohol and drug system, and providing support to primary care. So I think that sort of clinical hub and spoke model of a tertiary clinical addiction stream of expertise would provide, a huge boost in terms of addressing the many harms associated with addiction issues that we see across our general hospital, primary care, alcohol and drug and mental health settings. And I think that is a priority in terms of if we want to address the issues of integrated care.
Thank you very much. Oh, sorry, Dr. Gruenert, I'll go back to you.
Can I just add there, I think that's a really important issue, but I see it as a two-way thing, drug treatment sector also needs the support around mental health to ensure that we don't, we can manage most of the people that seek help from us within our. So I see that sort of model that Dan was talking about as a two-way thing. So we're actually bringing in the mental health expertise into drug and alcohol as much as we're putting drug and alcohol expertise into mental health.
Can I just add on that, Stefan? I completely agree. So for example, as I would see in this stream, we would have an addiction psychiatry stream. So we run an addiction psychiatry clinic at Turning Point. And I can tell you that we have to stop our waiting list because we have less than 0.5 EFT to offer that clinic, and we are inundated by AED providers and GPs and the mental health system asking for advice around how to manage the cases. So you set one of these things up, there is huge demand in the system, both providing the addiction mental health piece. We know that this is a huge gap, and we know that there's a huge demand, but this is a huge missing piece. And my colleagues, unfortunately, my colleagues who work in private mental health, in the private system, again, there's very limited expertise in addiction. And, we get referrals of many hundreds of people who just cannot access the right treatment in the private mental health system because they have a co-occurring substance use disorder, and our private colleagues don't feel they have the expertise to actually manage that comorbidity.
Okay. I'm going to hand over to the Chair now, unless there's any final comments. Okay, thank you, Chair. I'll hand over to you for the Commissioner's questions.
Thank you very much, panel members, and to you, Fiona, as well, for leading that discussion. It was fabulously informative and has, I think, given us a lot of insight into what some of the opportunities as well as the challenges might be in terms of us building our future system that's more responsive to these issues. And I guess one of the issues, and just to go to your suggestion, Professor Lubman, about the series of clinical hubs that could inReach, do you think that would make a difference to some of the volatility that we currently see? I think we all talked about the stigma associated with mental illness and drug addiction. We've got real challenges right now in Victoria where we hear from consumers, we hear from service providers about the fact that too many people are getting very unwell, presenting, police picking them up or ambulance, being taken to an ED, some being admitted to an inpatient unit in highly agitated, volatile states, no one feeling that well able to cope with it, having high incidence of occupational violence and associated issues. And so we're, in addition to taking a long-term strategy about how are we going to improve our capability in this sector, face some pretty immediate challenges about whether or not we're running services or have models of care that are providing for the safety and needs of all consumers. So is there models of care that are available that can help with this? Are they existing in Queensland or other jurisdictions? But can you just talk to us about how you think we might address this issue? Because it is exacerbating problems, but also adding to the stigma around these issues in the community and in service providers.
Yeah, I mean, I think it's a really great point. I would say there's a couple of things here. One is that there's a belief in the system that treatment doesn't work, that there's a nihilism across the health system, across the police system, across the paramedic system, across EDs, that if you have an alcohol and drug disorder, that basically, there's no way you're going to recover. That's what we hear consistently in the media. We don't have any visible champions out there telling us that there's anything different. If nobody spoke up about recovering from cancer, what we saw 30 years ago, when we didn't see anyone who would actually recover from cancer, was a belief that cancer was a death sentence. And because of that, people, when I trained as a medical student, I would see people presenting to cancer clinics with end-stage, cancer, because they were so embarrassed that they had cancer. They feel nihilistic around feeling there was any treatment, that they didn't actually seek treatment until they had all these complications. So I think the issue for us is because of this failure to have a clinical addiction stream, nowhere in the undergraduate or postgraduate training or in the everyday lives of people who work in the health system, do they come across people who actually are experts in this, who can tell stories around what works, can actually demonstrate what the interventions actually are. There's none of that visibility. So for me, one of the biggest issues working, I'm fortunate to be able to work in a large hospital network, and I'm able to go to medical grand rounds with my colleagues from ED and psychiatry and general medicine, and I'm able to work across those distance bases. And certainly when I first started in this role, all I heard consistently was, why do you see these people? They never get better, nothing ever works, it's a waste of time. They should be, they should be treated in the criminal system. And it's only by actually being there, being able to be, part of the system and demonstrating what is possible, that we're actually able to change people's views and attitudes in this space, because the evidence is pretty strong that we have evidence-based treatments that actually work. We don't have to go far to actually search high and wide for them. There's very good, strong evidence of good treatment models for the treatment and good outcomes for the patients that we see. In fact, people with schizophrenia, for example, who don't have a substance use disorder, have worse outcomes long-term in terms of their prognosis than people with a substance use disorder. So substance use disorder is a good predictor of good prognosis, because if we address that, it's likely that their psychosis will massively improve. So there's all these positives around, how, what we can do. The issue is that we are not present in the health system. We're not with colleagues in other areas of health who see what we're able to provide. We're not working alongside paramedics or police or other aspects of the system. And so there's a general nihilism in the community. People don't come to treatment until it's too late. People don't believe it works. People don't think about referring us to actually have evidence-based treatment. So for me, this is a critical gap in terms of presence and visibility and our ability to influence, what can happen in the health system.
And can I go to you, Dr. Reilly? Is that different in Queensland where you've got an integrated model, or are you equally challenged by the issue that we're facing here in Victoria at the moment?
No, absolutely equally challenged. I think that, though, I understand what Dan's saying, and I don't disagree fully, but I do think that psychiatrists have been dealing certainly with people presenting with substance-related psychosis and acute psychotic episodes not related to substance use with aggression for a very long time. So I actually do think that they can manage and contain that. I think that the challenge is, though, that if it is in fact, say, amphetamine related, then they don't have a mindset that this is an ongoing issue that they might now need to be involved in addressing and working with. They don't feel confident, and instead what they want to do is to say, oh, it's amphetamine related, it's not my problem. Someone else should be coming in and taking responsibility for that, rather than, in a sense, taking over the ownership of that, because we haven't set up that sense, as Dan said, that this is something that they need to do. We've instead allowed that to be externalised. So I do think, they can manage the acute, but they don't, they will complain about that because they don't see it as really something they should be doing, along the lines that Dan was just saying he's always had. It should instead be something else that someone else should somehow deal with, whether that's the criminal justice system or somehow some other magic specialist who's going to come along to deal with this issue. I think that's a fantasy, but nevertheless it continues to exist in many mental health services and clinicians.
Thank you. Dr. Cockram, do you want to ask the panel a question?
Yeah, my question, I think I'm going to ask Dr. Gruenert this first, but if I could, with this single question, come back to Professor Lubman. If we postulate, and the group has postulated, the potential opportunities of creating a more cohesive shared vision at a department level of both AOD and mental health, and perhaps having a policy and planning setting that supports that. But I also think that you have particularly highlighted the importance of maintaining a commissioned service system that is fit for purpose and separate where needed. I'm interested in your thoughts where we bring those systems back together again, perhaps in integrated community environments, and people have talked about that. How do we governance to support both models of care at that more local integration as opposed to at the State Department? And have you seen shared governance models or collaborative models that you think might work? i.e. not one or the other, but both is what I'm asking.
Thank you for the question. I think where I've seen it work best has been in escalation models for more complex people, and I've certainly raised this issue with the chair in terms of some services that Odyssey ran in New Zealand, where people in residential drug treatment services, if they become particularly unwell around their mental health issues, have meant they've been unable to really participate in drug treatment, and the size and scale of those programs, it does not support the sort of de-escalation of those symptoms and management of those. And there's been a specialist dual diagnosis program that's residential, smaller numbers, and it has access to psychiatry and addiction medicine and higher staff to resident ratios, and it's been really effective in stabilising, suicidality and people who, have schizophrenia, who may be able to manage it from time to time, but it escalates into psychosis at times. And that's been well integrated and managed well. I think equally, if you're talking at a local level in some of the psychosocial services, there has been a greater propensity, if you're talking about recovery, to integrate some of the sort of higher prevalence but lower severity issues across drug treatment and mental health. So I think, but again, it's usually been because you've got some skilled clinicians who are experienced enough and know where they can get support or access others to be able to do that. I haven't seen, and I haven't read any evidence or seen examples where there's been that full integration of service provision at the local local level between two systems working well. All I've ever heard about is why it failed and the tensions that existed and then people going their separate ways again. And it's largely come back to philosophy's approach and also some differences in the cohorts. You know, your services are better supporting these and more of your services are oriented to emphasise that and more of ours are oriented to service this. Now, to some extent, that's an example of what is and what, you know, rather than what could be. But I think a lot of the things we're trying to grapple with here, including the chaos in the system and presenting to ED, are symptoms of the system failing. And, you know, you're always going to need some emphasis at that critical crisis bottom of the cliff to end. But if we're getting the other parts right, and that may just be properly resourcing both systems to do what they need to do, I think we're going to avoid a lot more people presenting in crisis and really needing a full integration, even at a local service level.
Thank you.
Thank you.
Professor Lubman, can I just sort of shift the question slightly? I guess if there's a shared vision, can there be a shared accountability at a system level? And particularly, say, in a community integrated clinic or any other environment, is there something the Commission should be thinking about saying that rather than either or, that we're creating some opportunity to get collaborative and shared accountability for a general success for a group of people as opposed to one or the other?
It's a great question. I suppose the thing that I suppose I would reflect on that question is this issue of differing populations. So there's clearly, I think we've got a Venn diagram. So we've got one sphere here that is clearly in the remit of alcohol and drug services. There will be some part of that Venn diagram that overlaps with mental health. And similarly, we've got the mental health system that largely sits in the purview of the mental health system with a small overlap in terms of the alcohol and drug system. And then it's where there's overlapping nature. That's where I think where we need to target. And I think, I suppose my experiences of that is that we can get shared governance arrangements and agreement as long as, there's a couple of issues. One is around how do we incentivize it and what are the relevant policy levers around that. But I think we can all share, and Stefan might be able to comment on this as well, I often find it's harder to actually do something in a shared way with other services than it is to do it by ourselves. The system actually puts in perverse incentives to make it more challenging, both in terms of our funding structures, in terms of our reporting, in terms of our information sharing, in terms of our expectations. So the system actually creates incentives not to work together. So in terms of having that shared governance, it's around making sure the system is incentivized to actually work together. And so identifying what those barriers are to working together and actually looking to overcome them. But my experience is when you have organizations, and I've been involved in multiple projects where we've had the senior leadership team of one organization and another, I recognize that this is what we want to do. We've got common sort of goals and a shared perspective, and we want to work together to do that. We've got some really great examples of where that's worked well with the appropriate resourcing and the ability to direct resources to do that. So I don't think that's too hard, but there's challenges in information sharing and other sort of bureaucratic processes that sometimes inhibit the ability to actually deliver that.
Okay, thank you.
Thank you. Professor Fels.
I was going to ask a kind of conciliation type question, and maybe you'll find yourself just repeating what you've said, but I was going to ask one of Dr. Reilly and then Professor Lubman. I mean, Dr. Reilly, suppose, contrary to what would be your wishes, I think, you received an edict from on high to go back to a more separated system. What would you insist should happen in that case? And then I was going to ask Professor Lubman the opposite, having heard a litany of reasons why the subject matters are different and there should be a degree of separation. But supposing contrary to all of that, there were some move to more substantial integration. What would your log of demands be? As I said, I think we've heard a fair bit already, but I still would find it just useful to hear an answer to those unthinkable propositions. Maybe Dr. Reilly.
Sure, thank you, Professor Fels. I think absolutely would be unwanted, of course, but if so, then at a departmental level, fine, those things happen. And even then, if there was a disaggregation at an HHS level following on from that, and teams were teams were separated out again, I guess I'd still say that I think from a clinical point of view, at the level of the consumer, what we should be looking to do nevertheless is to say that you can't split that, that's not actually a kind of government decision, that's actually about evidence-based care, that the evidence-based care is for an integrated model, and that, sure, we can split all of the systems, but we nevertheless have to create structures which support and encourage those integrated models of care. And that includes, at the very least, training models which ensure that people working in both separate areas actually have experience and work closely together and ensure that those training models cross over if it's been completely de-integrated. But it doesn't make sense, unfortunately, to go that way, but that's what I would be perhaps arguing for most.
I suppose the point I wanted to raise was that often what we're doing is we're trying to retrofit systems. So we have things that we wouldn't design in the first place, and then we're asked to how we put them together to somehow solve a problem that's very complex. And so in that context, I think for me, the thing that we would really need to do very carefully if we were to integrate systems is we would have to take a step back and be really clear about what it is that we're trying to achieve. So for me, I think where we often fail to do the work is we don't do the work in terms of demand modeling, understanding who are the populations in need, what are their characteristics, what do they need, what is the most appropriate way in which to sort of set up services to meet the different population needs that we see. We don't then think about what is the evidence base and the care models that we have to create that are the most effective. So looking at the population and breaking them down and seeing how they look and seeing how we might need to step up and step down on models of care. We don't clearly define what those models of care are and what the competencies and workforce makeup of those models of care actually are. And overarching that, then we don't think about the quality framework and the principles of care that underpin how those systems are designed. So for me, I think if we were to start from scratch, for example, and you were to throw everything up again and we were to redesign the whole system, for me, as long as we took a really clear, evidence-based, pragmatic approach where we looked at what works and we design a system that actually meets the needs of individuals and actually articulates what it is we're trying to achieve and what workforce we actually need to do that, I would feel very confident in that space. My concerns is that we don't tend to think in that way strategically. We tend to say, well, we've got service X and service Y. You guys work together now and make it work without any investment in models of care, the appropriate workforce, the clarity of the framework and the principles of work we want to achieve. So for me, they're the things I think we need to think very carefully about.
Thank you.
Thank you. Professor McSherry.
Yes, I have a question about legal frameworks for Professor Lubman. And I was interested when you started off, you mentioned how the Mental Health Act and risk approaches has really driven where we are now with the mental health system. We've also heard a lot throughout the course of this commission about stigma in relation to both sectors. We've heard a lot about law and order agendas and so on. So I'm interested to get your perspective on the fact that we've long had legislation that enables compulsory treatment in the alcohol and other drugs sector. And at the moment, we've got the Severe Substance Dependence Treatment Act. And yet that hasn't driven the AOD sector. And I'm just wondering whether you have any perspectives on why that might be the case, whether it is just a matter of people falling within the compulsory mental health system instead, or whether there's something else going on here. Great
question. Look, I've got to say the Severe Suspended Act is not a very workable act. If you look at the number of people who've used that, who've come under the remit of that act, you know, we're talking a very small percentage of the population. It's very difficult to navigate. There's a lot of confusion around who's eligible. There's a lot of confusion around, well, there's a lot of processes in place in terms of how to make it work. And the duration of the act makes it a disincentive to use the act, because it's only relevant for a certain amount of time. So by the time you've got somebody in and using it, you know, obviously we're talking about issues that are long-standing and complex, and using it for a very distinct period of time, a short period of time, is really not workable. There's also, I mean, I think the biggest issue is, you know, I think within the mental health space, there's greater clarity of, I suppose, when somebody is impaired in the mental health space. I think, as Stefan has, you know, talked about before, you know, particularly in the alcohol and drug space, it's an incredibly political issue. So anyone in some ways who chooses to do something illegal is in some way impaired in one context. And so, you know, there's a whole political overlay of what impairment means in the alcohol and drug space. And I think, you know, certainly we see that every day when we are dealing with family members who come with us concerned about their loved ones and feeling, you know, unable to do anything, and wanting us in some ways to forcibly, you know, apply treatment to people, you know. And I think, you know, the challenge is for us is around having a system, you know, often when we, and I said as my submission, you know, often when we create systems that are underpinned by legislation, we actually create resources to enable that person to get good quality care. The downside of a non-mandatory system is we have services that aren't adequately resourced to actually meet the needs of the individual, and I think they're the tensions that we constantly struggle with.
Thank you.
Chair, sorry, Dr. Gruenert has got something further to say, just in case you missed it.
Thank you.
Commissioners, I just want to add one thing to that comment. Very few people actually access the drug and alcohol system on a voluntary basis. Even though they might not be mandated under any act to do that, they're all experiencing some pressure usually, and that may be pressure from child protection because they're going to lose their child. It might be some legal issues that are pending that are going to have significant impact on them if they don't choose to engage in treatment. It might be pressure from a family member or a friend, or to be kicked out of home, or a health issue that's pending. So there's lots of other levers that motivate someone into treatment, which is, I think, also one reason why we wouldn't see that the use of the Act as much as necessary. And I guess for me, it's critical, whichever decision or way the Commission chooses to go with these services and the system and how it's designed. For me, a fundamental is, if we're continually assessing the voices of consumers and those experiencing the system and the outcomes it's achieving, and evolving the system over time, then I'm always open to you know, one model versus the other, and trialling different things in a sort of a real evidence-based and an evolution of the system.
Fantastic, thank you very much. So, panel members and Ms. Batten, thank you so much for the discussion we've had today. It's been incredibly informative. It was very helpful, as I said at the beginning, for the commissioners to read your witness statements. Even greater help for us to hear and have the opportunity to discuss some of these challenging issues with you, and to reflect upon what you think is the desirable future system. And it is definitely work in progress. You know, there is a level of flexibility required in our thinking about what direction we want to pursue. And given the government has committed to implement the recommendations we put forward, we have a great sense of responsibility to do no harm in terms of ultimately what we recommend by these systems, and recognise both the strengths and opportunities for that, both service systems, and the strengths that the AOD sector has to bring to the table, as well as the mental health system. And so this has been a very, very helpful discussion for our deliberations. So thank you very much for your time, and particularly Dr. Reilly from Interstate, thank you for being so committed to helping us in terms of trying to design a future mental health system here in Victoria. So thank you all for your participation.